very good evening, everyone. I'm Dr. Deepika from BSV, and I'm delighted to welcome you all to Perfection Fertisphere by ISAR Symposium 9.0. Please note that there is certificate of attendance at the end of today's session, so we encourage you to stay with us throughout the program. Today's discussion focuses on a very important and a very interesting area, and that will be the ART mixed bag in reproductive medicine. We look forward to an engaging, insightful discussion with our distinguished faculty and expert guests for the evening. To set the tone, it's my pleasure to introduce our convener, Dr. Monica Singh Ma'am, a trailblazer in the field of reproductive medicine. Ma'am is MD DNB with fellowships in minimal access surgery and also of the Indian College of Obstetricians and Gynecologists. She currently serves as President-elect Bhopal Obstetric and Gynecological Society, Founder President ISOPAB Bhopal Chapter 2024-27, National Executive Member ISAR 2024-27, and she is also the convener behind several impactful academic initiatives, including the ISAR Perfection Series, the Foxy Symbiosis Series, and the Synergy Academic Club. We welcome you, ma'am. Over to you.
Thank you, Dr. Deepika Mishra, and thank you, Team BSV, for this academic platform for ISAR Perfection Fertisphere series, a series which is now on the ninth episode. And at the outset, I would like to thank Indian Society of Assisted Reproduction for giving us this opportunity to host this academic feast with all of you. Today is the ninth episode, and this is assisted reproductive technology mixed bag because there were several topics we wanted to touch, but because of paucity of time, we thought of putting them all together. So we have got lots of dignitaries from IAG. Sudha Tandon ma'am is very much here. We have got ISAR Secretary General here, Dr. Asha Bakshi. We have got ISAR Chairman Embryology, Dr. Charudat Joshi, who have joined us. And we welcome our President ISAR, Dr. Amit Patki. He will be joining very soon. He is busy with another meeting. Madam Bakshi is there. Our chief guest for the evening is Dr. Atul Ganatra, who is immediate past president of Indian Association of Gynecological Endoscopists. Our special guests for the evening are Dr. Andaleep Agrawal, past president of Prayagraj OBGY Society, a very keen academician. Dr. Sudha Tandon Madam, who is vice president of IAGE. We have our guests of honor for the evening, Dr. Charudat Joshi, chairman embryology of ISAR, Dr. Pandit Palaskar sir, who is past president of IAGE. So I'll just walk you through the program, which is definitely going to be a very interesting one. To set the tone of the webinar, we to start with, we have got fertility enhancing endoscopic surgeries. Definitely, endoscopic surgeries is a very exciting topic, but to reproductive medicine specialists, it is all the more important because we feel that this can be a key component of the overall treatment of our patients and towards them achieving a healthy baby. So, Dr. Saumil Trivedi will be deliberating on this topic. Chairpersons are Dr. Malaraj, Dr. George Paul, and Dr. Damodar Rao. Next, we have got a very interesting topic which Dr. Pratik Tambe spoke on in ICOG, and that time I heard him and I was mesmerized with this talk. So I thought, let me put it in Perfection series because obesity is a pandemic nowadays, which is even taking over Southeast Asia in a very big way, especially India, because of the lot of carbohydrates and sugars we are consuming. So, how does obesity impact human reproduction? This will be deliberated by Dr. Pratik Tambe. The chairpersons are Dr. M.S. Srinivas, Dr. Randhir Singh, Dr. Natachandra Chimote, and Dr. Anuradha Khar. Next, we've got troubleshooting in ART. Here, we thought we'll troubleshoot not only in the clinical aspect but also in the laboratory. So, I'll be taking a case on endometriosis. Dr. Padmaja will be tackling a very, real life case of difficult OPU which she encountered recently. And Dr. Manisha Bajpai, also our co-convener, will be tackling two difficult cases where they had troubleshooting in the lab. And the panelists are drawn from all over India. And we have two experts, a clinician expert, Dr. Uma Satvik, embryologist expert, our past chairperson, embryology ISAR, Dr. Viren Shah. So without wasting time, we move to welcome of our dignitaries. Dr. Amit Patki will be joining very soon, but Bakshi Madam is there. And we thank Bakshi ma'am for sparing the time. And madam is going for election in ISAR. We wish madam all the very best. We know that madam is leading the ISAR organization in a very active and positive way. We have no doubt that madam is going to be the leader for our organization, and we invite madam to speak about ISAR and the program and her campaign.
Thank you very much, Monica, for the kind introduction. And I'm really proud of you that you are doing such good webinars. And this is a webinar especially on ART mixed bag. So, and the topics you have selected are really good. Endoscopy, which is the friend of IVF specialists, and troubleshooting in ART, and obesity again. So, very good topics you have selected, which would be of interest to everyone. Um, and I'm really thankful to Dr. Amit Patki for taking ISAR to such great heights. And I would like to welcome Dr. Atul Ganatra, who is an excellent clinician and a very good endoscopic surgeon. Dr. Anjali Agrawal, Dr. Sudha Tandon, my good friend, Charu from Indore, then Dr. Pandit Palashkar, and of course, you both are there, my good friends Randir and Monica, and I wish you all the best for your future endeavors. And nice to see here Garima, Manisha, Neelam, who are the co-conveners of this webinar, and coordinators Dr. Ankita, Dr. Payal, Dr. Apurva. And so nice to see that the speaker is young, Dr. Saumil Trivedi, though young with vast experience in endoscopic surgery, and chairpersons, Dr. Mala Raj, a lady with a family of sports people. Then and that I think that's the reason she's so strong and able to do such good endoscopic surgery. Then Dr. George Paul, Dr. Damodar Rao, all they are. I know them very personally, and they are very good surgeons. And Pratik, there's no doubt about it, and he's going to do justice to this topic. And nice to, and again, I would like to welcome Dr. Srinivas, very senior embryologist, and he has taught so many people all over India. Dr. Chimote, again, a very respectable person. And he has fathered such good children, I must say. That he has taught them so well. And then the panel discussion is are very important, and that the way you described it, that how what case you are going to do and what Padmaja is going to do, that tells that this is really going to be very interesting. And I welcome you all, Manisha and Ruma, Dr. Viren Shah, Dr. Bhavika, Dr. Dharam Shah, Dr. Sethi, Dr. Gautam, Dr. Gauri, Dr. Jayashri, Dr. Meeta, Dr. Monica, Dr. Gaur, Dr. Niti, Dr. Nidhi Singh, and Dr. Richa. So, with this all, I would like to again conclude and just request at the end that I'm going in for the Vice President ESAR position. So, for the election, so please do support me wholeheartedly, and at least encourage everyone to vote. I think most important is to exercise vote, and that is the most important thing. So, as ESAR secretary, also I would appeal to everyone that everyone should exercise their right to vote. So, with all these words, I would like to conclude. Welcome, Sudha. So nice to see you here. Dr. Pandit Palaskar, welcome, a very warm welcome. So, thank you so much.
Thank you.
Thank you, Aisha ma'am. I think we have given a message very well, ma'am, that the percentage of voting is very less. It's hardly 50%. So, ma'am,
So
I think
people
we'll
should vote.
request,
I
yeah.
think that is most important.
Yeah, we'll request, Madam Patki sir also, sir, that official broadcast will be regularly, because democracy true is the percentage of votage.
No,
Thank you,
they will usually they broadcast. Means
Yeah.
in a day or two, it will be there on message. As so, everyone should check their message. In that, you'll get the link, and then you'll be able to. So, definitely everything is done from our ISAR side, so that people are encouraged to vote.
Actually, but I mean, other associations, what they say, ma'am, suppose we have got a 6,000 members and 1,000 members voted on the first day. So, who have not voted, second day, they will only, those who have not voted, they will get the message. Please cast your vote. Not everyone.
I don't think the message just goes. That's it. We can't do that much, but
Yeah, that is
it's a
very
good
technically
suggestion. We
advanced.
may ask. We may ask. Hopefully, in my tenure, I'll ask keyboard people to do this way.
Well, yeah,
Okay.
ma'am. That is the real advantage of AI. Yeah.
Yeah. Yeah.
Yeah, as of now, as we are speaking, Dr. Amit Patki is doing a mock meeting, a mock voting with eVote right now.
Okay.
So
Okay.
his appointment was exact at 5 p.m. and our webinar was also starting at 5 p.m. So Dr. Amit Patki is, testing the voting nitty gritties, and I'm sure ISAR has always sailed through these elections without any controversies, without any
No,
complications of.
and the elections are done very smoothly and very transparently because last year I was the scrutinizer, so I know that how it goes. So it's a very good process.
Yes, ma'am. So now, thank you, Asha ma'am. And I now invite our chief guest for the evening, Dr. Atul Ganatra. And I request my coordinators to please put a phone call to Atul sir. He was in the OT when I last called, but please remind him. Till then, I will invite and welcome our special guest for the evening, Dr. Andalip Agrawal. Can I have Madam speak, please? So that Dr. Andalip Agrawal, can I yeah, request every.
Monica, Pandit sir has come, Monica.
Pandit sir is there, but Atul Ganatra sir, we are waiting. And we are now going to invite Dr. Andalip Agrawal to the program. Madam is our special guest for the evening. A special guest is someone who is special to us and special to the program. I have been meaning to invite Andalip ma'am for such a long time. She is a very, very soft hearted, gentle, and very nice soul who has always supported all Foxians in activities and encouraged juniors and mentored so many. Madam has been the past president of the very prestigious Prayagraj OBGY Society. Madam, the stage is all yours. We would like to have your blessings.
Thank you, Monica, for this invitation. Good evening and a very happy new year to everyone, the conveners, the coordinators, dignitaries, faculties, and audience. Firstly, I'd like to thank you, Monica, for inviting me as a special guest to one of my favorite and definitely very prestigious ISAR platform. I actually do not know what a special guest is supposed to do or is, but this webinar, the ISAR Perfection 9.0, is indeed precious and extremely special to me. I'm glad we would be discussing some very salient aspects of human reproduction and fertility, which will be presided over by the ISAR President Dr. Amit Patki, ISAR Secretary General Dr. Asha Bakshi, the chief guest, Dr. Ganatra, Dr. Sudha Tandon, Dr. Charudat, Dr. Pandit Palaskar, and all learned chairpersons of the sessions and experts of the panel. My regards to everybody. The speakers, Dr. Pratik Tambe, my very long time friend, Dr. Somal Trivedi, illustrious son of my ONG icon, Dr. Prakash Trivedi, will be discussing obesity and endoscopic surgery, and I'm sure it will be to a point of excellence. And the panel, troubleshooting in ART, will definitely be the icing on the cake with moderators Monica, Padmaja, and Manisha Vajpayee, who will make it interesting and bright with inputs coming from young, talented, and beautiful panelists. My blessings and best wishes are always with you, Monica and Randir. Today, more profusely for a smooth and wholesome completion of this event. So, I won't be taking any more time. I take your leave and I'm leaving behind the best vibes of blessings and love. Thank you.
Thank you,
Thank
Agrawal ma'am. Thank you, Agrawal ma'am. Actually, I am from your town. I am from Juicy, the Sangam area. My native,
Oh,
I was born in the Kamla Nehru Hospital. So
oh,
thanks,
I
ma'am. I
worked
have got
there for
respect.
15 years
Yes,
in
ma'am.
Kamla
Sangeeta Agrawal,
Nehru.
ma'am. Thank you, ma'am.
So, ma'am, we always hold you in high esteem, and all your blessings are very, very precious for us for starting the program. Thank you for being there, Andali, ma'am. And I
Yes.
would now like to invite our special guest, Dr. Sudha Tandon. Dr. Sudha Tandon ma'am holds the very prestigious post of Vice President of Indian Association of Gynecological Endoscopists. She is a very, very pleasant and very dynamic personality who leads with a gentle touch. And a leader need not always be strict and, like a leader. She is a very soft hearted leader who leads gently. That is all I can say about her with a beautiful smile. Very knowledgeable, very amiable, very approachable. So, ma'am, we are so honored to have you with us today, and we would like to have words of blessings from you, madam.
Thank you, Monica, for inviting me and for your very kind words. And uh, my blessings and best wishes for this webinar. All the dignitaries who are there, Dr. Asha Bakshi, Dr. Amit Patki, Dr. Atul, Dr. Pandit Palaskar, and all you have mentioned the names. I will not repeat them, and it's really nice to meet all of them, even if it's on Zoom platform. I think it's really lovely, and my best wishes to Dr. Asha Bakshi, to you, and to Dr. Randhir for the upcoming elections. And I think Dr. Garima is also contesting. She's the co-convener who called me up. And yes, I think you're doing a great job in these webinars, and the topics you have chosen, I think, really deserve a little bit of mention, because I think they are very complementary, endoscopy and fertility. And I think it's very important to see a patient as a whole, not just, what surgery we can do or whether we can do IVF. I think what is best for the patient needs to be discussed. I think I am of that opinion. And yes, all the best for this webinar and for your future also. Best wishes.
Thank you.
Thank you, Sudha ma'am. Thank you.
Thank you, ma'am. Thank
Thank
you.
you so much, ma'am. And next, I would like to invite our guests of honor for the evening. Pandit sir is there, Charu sir is there. So, can I have the CV? Dr. Charudat Joshi is heading ISAR as chairman of embryology. He belongs to the city of Indore, which has produced so many leaders in FOXY, IAG, and ISAR. Sir is postgraduate in life sciences, doctorate in life sciences, and he is the leader of the largest ART bank, I think, in central India. He is affiliated to several organizations, leading all the organizations very ably. Sir is also the past vice president of ACE and the past president of the ACE, that is Academy of Clinical Embryologists, from 2014 to 16. The name of Sir's ART Bank is Genes India ART Bank Indore, and he's also looking after as the lab director of RD Gadi Medical College Ujjain, which is a very prestigious medical college of Madhya Pradesh. Sir, we would like to have words of blessings from you. Welcome.
Thank you, madam, for such nice introduction. And it is always been a pleasure to be part of the Perfection series, which you have started under your able leadership and with the vision of Dr. Amit Patki, our president, Dr. Bakshi madam. And I think today this is the best platform to interact and share the knowledge. So, and on behalf of ISAR, I would like to welcome all the speakers and the moderators and everyone involved with this webinar and wish a great success. And thank you for involving embryology as a part of this webinar also, because that is the time, that is need of the time that this should go together. And I think ISAR has done fantastic job under leadership of Dr. Patki and Dr. Bakshi, that embryologists are also got a platform and now interacting. So this all is very good and wish you all the best. And thank you very much.
Thank you. Thank
Thank
you,
you.
Charu.
Thank you. Thank you, Dr. Charu. Thank you.
I would now like to welcome our guest of honor, Dr. Pandit Palaskar, sir. Sir is the past president of IAG, year 2023 and 24. He is a leading gynec endoscopic surgeon and IVF specialist practicing at Endoworld Hospital in Maharashtra, and a renowned hospital where many junior students and aspiring endoscopic surgeons go for taking training directly from Sir. This institute is IAGE and AAGL recognized center for endoscopy training and also a teaching hospital for DN students in OBGYN. That tells us volumes of Sir's passion for teaching. It is also a Foxy recognized training center. Sir is a renowned faculty speaker at conferences internationally as well as nationally with several published papers. We know him as a very humble and down to earth, very polite and soft spoken leader of IAGE. Welcome, sir. Always looking for your blessing, sir. The stage is all yours.
Hi, good evening, everybody. Thank you, Monica Madam, for the kind introduction and inviting me here on this Perfection Fertisphere webinar series. All respected dignitaries, Dr. Amit Patke sir, President of ISA, Dr. Asha Bakshi Madam, Dr. Randir sir, Dr. Charudat Doshi, and all the esteemed organizers and faculties and office bearers of the ISAR. This Perfection 40 Space series is a unique series. I have attended many of them and really have learned so many things from this webinar series. So, very thank you and congratulations for organizing such a beautiful series for the ISAR members and the all gynecologists from across the India. Today's webinar, it is a ART mix bag containing the endoscopy as well as ART also. So friends, the endoscopy and infertility, they always go hand in hand, and our ultimate goal is to improve the pregnancy rate. So we can't practice only endoscopy and give the pregnancy, or some infertility specialists can't say, I will not do the endoscopy. So we have to use both modalities to optimize our pregnancy rate. So you have wisely chosen this topic, fertility enhancing surgeries, and that will be delivered by the eminent faculty, Dr. Saumil Trivedi. Other topic I like, that is troubleshooting in ERT. Every day there will be some problem in ERT lab because it is all equipment based. There may be problem associated with stimulation, some inherent problem to the patient. So I think it is a very good topic, and whenever we organize conference on infertility or IVF, this topic is always there because it is most wanted. So I think this will be very useful for all the clinicians, embryologists, and all delegates. Definitely, this webinar will be very good for everybody, and it will enhance the knowledge in endoscopy as well as the infertility. So thank you so much for inviting me, and I wish you all the best for this webinar as well as the forthcoming elections of the ESR. Dr. Monica Singh and Randir Singh, they are always, I know them since last 25 years. They are always in the forefront of the infertility. They are very good academicians. They have so many publications. They don't do only the clinical work, they publish it. I have seen you publishing your work at ISRI. So I think you should represent the India at the ISR level and international level. So you are most wanted, and you deserve the bigger post in ISR. So we wish you all the best for the ISR elections. We are always there to support you. We will convey our friends also to support you. Thank you and all the best.
Thank you,
Thank you.
Pandit sir. Thank you.
Thank you.
Now I would like to just thank all my team with a small note of thanks to all of them for pitching in and getting these webinars together. When we start these webinars, it's once we finish a webinar, we are also exhausted and drained. We cannot, for 24 hours, we cannot think straight. But after 1 or 2 days, we start planning the next. So when we start planning, it is always the not the whole team pitches in at the same time. I cannot withdraw at any moment but still sometimes I withdraw, and there are co-conveners and coordinators who do the whole job. So this whole show which you see me convening has been put together by a team. So I would like to acknowledge my co-convener, Dr. Randir Singh, who is managing committee member of ISAR and governing council member of ICRM. So myself and Dr. Randir humbly seek your vote and blessings for the forthcoming ISAR elections. Next, I would like to thank my co-conveners. My co-conveners are three dynamic, active, and very, very hardworking managing committee members of ISAR, Dr. Garima Sharma from Mumbai, Dr. Manisha Bajpayee from Udaipur, and Dr. Neelam Vise from Mumbai. So these three bring together ideas which we, give them the life. Their ideas come into life through these webinars. We envisage the topics, the speakers, the age of the speakers, the audience, and then all this platform is broadcast on YouTube, and the YouTube link is available for anyone who wants to watch the webinar later. So I thank all of them, and I also thank my coordinators. My coordinators are Dr. Purva Bhatkur. She is Associate Professor, Gandhi Medical College, the largest medical college of Bhopal after AIMS. Next, I have Dr. Payal Raghuvanshi, who is a fertility specialist from Bhopal, and Dr. Ankita Upadhyay, who is Assistant Professor at Chirayu Medical College, Bhopal. Thank you to all three of them for working day and night to give this program its success and its dignity. Thank you so much. I now hand over the, after long introductions, I hand over the platform to Dr. Garima Sharma to start the first session. Thank you so much.
Thank you, Dr. Monica, for the very kind words. And yes, it's a blend of the teamwork. And today we are with the theme of mixed bag. When Dr. Sudha Tandon rightly said that in practice, it's treating the patient in totality and not doing whether I would want to do only endoscopy or whether I would want to do fertility, and to put the highlights into the complete management of the patient. We have today Dr. Saumil Trivedi topping on fertility enhancing endoscopic surgeries. May I now invite the chairpersons for this session? Can I have the CVs? Dr. Mala Raj, ma'am, a very senior person in the field of gynec endoscopy, who's the vice chairperson of IAG Tamil Nadu chapter, founder secretary IAG Tamil Nadu chapter. She's also the managing council member of IAG, vice president Chennai Menopause Society, and has held several positions in FOXY, IAG, and the state organizations. She has also been recipient of the very prestigious awards like Best Doctor Award from Tamil Nadu MGR University, and she has been the invited faculty for various national and international conferences. I welcome you. Can I have the next CV? Dr. George Paul, a very dear friend who is a consultant and endoscopic surgeon at Paul's Hospital, Kochi, Apollo Adlux Hospital, and Devi Hospital. He's the scientific coordinator of Cochin Gynecological Endoscopic Training Center in Kochi and the managing committee member of IAG. Again, a national and an international faculty, and has been awarded with several awards, including IAG Young Skill and Excellence Star Award. Can I have the next CV? Dr. Damodar Rao, another young gynec endoscopic surgeon and a very close friend, consultant OBGY, infertility and laparoscopic surgeon at Rao Hospital. He has done his fellowship in laparoscopy from University of Louisville, Kentucky in 2012. He holds several organizational positions, including Tamil Nadu IAG Secretary, and he was the past IAG Joint Secretary, National IAG Management Committee member 2022 to 23 and 23 to 25. Also the recipient of Dr. Shan Ratnam Young Gynecologist Award at AFOG in 2022 and several other awards. I welcome you all, and the stage is all yours.
Thank you, Garima.
Yeah, thank you. Thank you, Dr. Garima Sharma. So good evening, everybody. At the outset, I would like to thank Isar and the entire team for organizing this beautiful webinar. So we have the first speaker for the day. We have Dr. Saumil Trivedi, who's going to talk on a very important topic, the fertility enhancing surgeries. As we all know, fertility and endoscopy go in hand to enhance the reproductive potential of the women. So many a times a women is on the crossroad, not knowing how to move about, whether to go in for IVF or to stick to the natural process or not. So in such a situation, there is one real good surgical technique which really enhances her reproductive potential, and she's able to conceive naturally, which adds so much of joy to her. So these are the fertility enhancing procedures which have really come up in a very big way to make these women pregnant. And then to highlight on this, we have our very, very good young and dynamic speaker, Dr. Saumil Trivedi, who has done a fellowship in this minimally invasive surgery, and also fellowship in obstetrics and gynec ultrasound, and also trained in robotic surgery, fellowship in embryology and infertility. And he is the youngest IAG managing council member, and Forbes India Insightful Icon Award has been awarded to him, and also recipient of IAG and AAGL Skill Excellence Award, youngest Indian invited speaker to AAGL to present his work, and has authored 13 publications and 49 book chapters. Recipient of Oxy Shuli Rudra Sinha Award, and recipient of the prestigious late Dr. Praveen Mehta Award by Foxy, and editor of the Foxy Ethical Evidence-Based Recommendations on Fibroids. So over to Dr. Saumil Trivedi to deliver his talk, please.
Thank you so much, Dr. Mala ma'am, Dr. Damodar. At the outset, I would like to thank the conveners of this session, Dr. Monica Singh, Dr. Randhir Singh, and all the dignitaries and stalwarts which are present today. It's really an honor to get an opportunity to present among such stalwarts of the field. So I'll just start sharing my screen. I hope it is visible.
Yeah, very well.
So just as very rightly mentioned by everybody, that endoscopic surgery and fertility management, like these are two sides of the same coin and are complementary. Now, whenever we talk about fertility enhancing endoscopic surgery, our basic targets or the things that we are looking at are the uterus, the ovaries, the tubal status, the peritoneal or the adhesion factors, and intracavitary lesions. Now, I just need to make a disclaimer that for the sake of maintaining time, I will be covering mainly the uterine factors today, because I think in 30 minutes, I presume that, like, it is better I do justice to one aspect rather than, like just touching upon multiple things. So coming to the uterine factors, and what I like to always seek is what actually are the uterine factors, what is the impact on the fertility, the risk stratification of doing a surgery versus not doing a surgery, and various classifications. So for me, as someone who practices both the disciplines, that is fertility and endoscopy, with equal passion, I think the simplest classification which I like to call is this: the absolute bullseye. Like the absolute bullseye, nobody is going to argue, or there's going to be no gray areas or dilemmas, that a 12 centimeter fibroid or a 5 centimeter cavitary fibroid needs to be removed. I mean, that is absolutely, like something which is needed for fertility benefit. The ones missing the target completely, wherein, yes, definitely medical management or other modalities for fertility may be employed. What are the tricky ones are these in between gray zone ones, which are the dilemmas. And most of the videos which I'm trying to cover are going to be focused on these gray zones. So as we all know, when we talk about uterine factors, just starting from the myometrium, coming into the endometrium, we are mainly referring to a host of fibroids, adenomyosis, various congenital uterine anomalies, and acquired uterine pathologies. So I'll start off with this very simplistic case, and I intend to just shed some light on basic principles and certain misconceptions regarding fertility enhancing surgery when it comes to myomectomy. So as we all know, whenever we are dealing with a myoma, what matters very much is hemostasis, and I inject and use a lot of vasopressin safely. There is a lot of dilemma, and sometimes I find it very confusing when some of the surgeons say that since it is a fertility enhancing surgery, I'm not going to use energy. There is no issue in using energy to make an incision. I mean, if you see out here, I'm using the ultrasonic scalpel. One can use a monopolar. Uh, what I very truly believe, that if your blood loss is less, you will reduce your chances of coagulation and damaging the myometrium. And the key is to remain in the right plane. So also for larger fibroids, yes, definitely, like uterine artery clipping via a temporary shoelace knot or a trick knot is something which I resort to. And many studies have in fact shown that even if the uterine arteries are coagulated or clipped, it does not affect the fertility outcome because of a rich source of collateral supplies. Now, coming to this principles of surgery, I like to break it down into whenever I'm doing a myomectomy, I like to take a clean, big incision so that my enucleation can be faster and swifter. It's important you can go fast in the first 80% of the fibroid, but the terminal 20%, which I break it down into the 80-20 principle, is where one needs to move with caution. Sometimes an over enthusiastic assistant, or even us as surgeons, like when we have the Myanmar screw in hand, there is that very satisfactory feeling when the fibroid is coming out. Okay, so that is where one needs to control, not apply too much of undue traction. Otherwise, it will lead in bleeding and avulsion of the vessels, and that is where there is risk of cavity opening. The other principle one must take care of is what you're seeing, this flimsy layer out here. Even though I'm trimming it a bit, but ideally it's best that we conserve this neurovascular bundle around the fibroid, because that is something very important in the healing aspect of a myomectomy. And obviously, barb sutures have revolutionized our suturing techniques, and we can now achieve a much more close to open surgery kind of closures with this multi-layered closure, which can be achieved with the barb sutures. Not that conventional sutures were not able to do that, but there was obviously an inclination towards a monolayer closure rather than a multi-layered closure. So just a few principles out here. The first layer can be done in a continuous fashion. And to reduce the exposure of the barb suture, the outer serosal layer has to be done in a baseball fashion, as this minimizes the exposure of the barbs exposed outside, reducing chances of adhesions and some reports of subacute bowel obstruction, which have been mentioned. So at the end of the surgery, if you see, the bleeding must be probably, like say 5 to 10 ml. And this is just to highlight the principles that use of energy, if you see in this, was done only and only to make the incision. When we are enucleating, if you're in the right plane, there is hardly any bleeding that occurs. And if you suture swiftly, again, there is minimal need of use of electrocoagulation. Again, coming to this case, these are all cases which have been evaluated, tried other modalities, and then we have resorted to surgeries. So this case, the only principle which I like to highlight, which many of the times is debated, is what type of incisions to take, like whether to take an elliptical incision or to take a linear incision when it comes to fibroid. There is this concept that if you take an elliptical incision, there will be too much of myometrial loss and subsequent healing and issues with uterine rupture. Now, if you see this case, this is like a bunch of large jamuns or grapes, like not grapes because they are much larger than that, but they are all clustered on top of each other with that uterus, which is seen right at the base. So what I want to highlight by this is not something, I just want to highlight the way I plan my incisions. Now in this, if someone decides to take an incision on the top, it's like, like you're digging your own grave and creating a lot of dead space, which will be absolutely a nightmare to suture back. So sometimes a good reconstruction is what we want. And to achieve that, it might be imperative that we take this large elliptical cut so that the enucleation is faster. And as a result, the closure and the suturing part of it becomes much more easier. Now, this patient, incidentally, was a case of a repeat myomectomy, had undergone a myomectomy with uterine artery clipping, had got pregnant later, and had come for fertility as a secondary infertility case to us. So we are seeing these degenerated appearance, but what I want to highlight with that incision planning is towards the end, when you see the fibroid is trimmed off and completely separated, you see the resultant space that we have to suture. Okay, so that is what I'm saying. The mindset of a endoscopic or a fertility enhancing surgery should take into account or factor in all these things. Now, these are the kind of fibroids wherein we are always sitting on the fence, like someone has been asking her that this fibroid is not coming close to the cavity. The uterus is seeming fairly intact. It's a broad ligament fibroid. But I mean, if there is no factors which are detected, the best that we can do from our end is give this patient a chance. So yes, even though the uterine cavity in this situation was absolutely normal, this patient had what we call as the pseudo broad ligament fibroid, which is projecting anteriorly. and also posteriorly. You can see the ureter out there with the peristalsis. Now, contrary to the belief that broad ligament fibroids are dangerous fibroids, like I'm totally of a different opinion. I feel they are the easiest fibroids to tackle with because number one, they have no attachment. The only attachment would be if we are dealing with some pseudo broad ligament fibroids, will be in the lateral part wherein it is just stuck to the uterus. You see out here how easily and effortlessly these get separated. And once you put in the Miyama screw, because it is not surrounded by that much of an attachment to the uterus, it literally walks out and pops out. And many of the times we might not even need to close these broad ligament defects via suturing. However, if someone noticed in this, I had made an anterior incision wherein I had transected or cut the round ligament to aid my enucleation. So in this situation, I'll be reconstructing. My preference for a broad ligament fibroid such as this, if feasible, would always be a posterior incision. Because if you don't suture and leave it open, a posterior incision just allows the blood or whatever is collected to drain off by gravity, and it does not create a closed space with blood collection inside. So if you see, this is the terminal part of the fibroid which is being separated, and this is where one needs to be a little bit cautious. But the fear of ureter and all these situations, if you're remaining intracapsular and lifting the fibroid up, it is really, like unwarranted. Uh, Usually the ureter, once we lift off such fibroids up, is at a very safe distance, and that fear is absolutely not justified. So as I said, this was the resultant dead space, which, like some amount of oozing can occur. And in this situation, because I had divided the round ligament, I'm just reconstructing it back and will be closing the peritoneum posteriorly to prevent adhesions. Now, again, a tailor-made case for any surgeon, but was told that okay, the fibroid is purely subserous. Like the uterine cavity is very nice and intact, and so we decided, since it was a large 13 centimeter fibroid, but for an endoscopic surgeon, this surgery is like a cakewalk, like, because it's like a 5 minutes job. You just take an incision, it comes out. What was surprising is that the changes that this fibroid had harbored, even though, I mean, the change does not per se hamper the fertility aspect, but if you see the nature of this fibroid with this bad degenerations, like, it felt like a worthy decision to have this taken out. And this is where I like to highlight one more aspect, that when we are talking about fertility enhancing surgery, one cannot have a narrow tunnel vision in terms of, from treatment to pregnancy conception. One has to factor in the entire journey of pregnancy, whether these kind of fibroids may impact the pregnancy outcomes, whether there will be chances of preterm labors or growth restrictions. And these are the factors that a fertility enhancing endoscopist must factor in. Now, I think these are what we call as the no-brainers, which are intracavitary fibroids. But I also uh, want to just share one sentiment, that I feel hysteroscopic myomectomy is one of the most dangerous surgery in terms of fertility enhancement, because many times if done badly, it can totally mess up the cavity and result in bad adhesions, and almost, like, you would see a patient following up with fluid in the endometrial cavity with no lining development. So I would like to use a word of caution out here. My approach, how it has changed, I'll be highlighting. This is the traditional resectoscopic technique, which we all are so conversant with. This was a large posterior fibroid, which was in the cavity, almost 4 to 4.5 centimeters. And we are taking these long linear strips. The important thing out here is the surgical tips is, don't take small movements, move the entire assembly so that you can get the bigger chunks. Push these segments up into the fundus and keep resecting. Speed of resection is very important. And the end point is when you see this pinkish hue, wherein we have to stop, and sometimes some amount of bleeding. Now, this is another concept wherein, like there was a big, this thing, if fibroids are present on two opposing walls, like we don't resect both together, keep it in different sittings. I mean, per se, if you saw this case, it was not multiple fibroids or anything dangerous. Another tip out here is that if you're dealing with multi-wall or like the anterior and posterior wall fibroids, always tackle the posterior one first, because if you tackle the anterior one first, the chips that you separate will just gravitate down, will obscure your view completely for the posterior fibroid to be done then. So deal with the posterior fibroids. Now, a few tricks to make these fibroids bulge more into the cavity, I'll be highlighting in the next video. But there are various techniques which we use intra-op to make these fibroids, which are like say grade 1, grade 2, to pop more and more into the uterine cavity, like the Hamu's endo massage technique. Now, this is something wherein, like you trust your ultrasound judgment. There was a fibroid which was noticed. If you see in the first view, there was absolutely no visualization of the fibroid. This is the Hamu's massage technique, uterine massage technique, wherein you just stop the inflow, allow the outflow to have a suction effect, and that is where more and more of the fibroid pops up. And you can also use the cold loop to use as a dissector in such situations. If you see out here, you're seeing that edge of the fibroid from the endometrial cavity. But these are the fibroids I like, as I mentioned, like these are dangerous fibroids, because in a bid to resect these fibroids, we have to shave off that part of the endometrium. Even though the end part is good and seems normal, we don't know the silent thermal damage that these fibroids may, the resection of these fibroids may do. So Lusmask staging is something which I use very rampantly, and I feel this is a classification of great help compared to some of the other classifications I'll be mentioning in my talk, which tells one the complexity and the difficulty anticipated while doing a hysteroscopic myomectomy. And this is really something one must follow, especially if there is a beginner or someone who is not very cognizant with hysteroscopic myomectomy. One very important factor while doing a hysteroscopic myomectomy is people don't understand that a 2 centimeter cavitary fibroid and a 4 centimeter cavitary fibroid, it does not mean it is double the size. We have to consider the third dimension, that is the volume, the location, the volume of the uterus in respect to the fibroid, because that will dictate how much space you have for intracavitary manipulation. So these are some factors. A 2 centimeter fibroid is not double, 4 centimeters is not double than a 2 centimeter. In terms of volume, it becomes almost 8 times bigger. So that is something which we need to comprehend and look at. So this is where a lot of my techniques in recent times has shifted from a purely resectoscopic approach to endometrium conservation. And this is again a case of multiple fibroids, which you're seeing, one on the lateral wall, the other one was almost at the fundus. So something which is bulging completely into the cavity, yes, surely, like you resect it off, shave it off completely. When you're reaching the terminal part of your, use as much of the cold loop as possible without activating the electrode, because that will prevent some amount of the endometrial damage. Get these chips into the cervix and take the resectoscope back again. And you can see there that this fibroid is almost completely resected off. Now, when it comes to the other one, this, if you're seeing, this is more like a grade 1 kind of a fibroid with a cavitary component. It's a large one. So again, here I will be switching from the intracavitary part, which I'm very safely and confidently resecting, and using various techniques out here, like the Hamu's endo massage. This is the usage of what the cold loop. Okay, so the cold loop, or sometimes there is a loop like the Collins knife, which is having an angled knife. So this is what I like to do these days, rather than going and digging deep with the resectoscope. Try and enucleate this fibroid out. This is something very similar to a Collins knife, but it has no energy. It is an absolute right-angled cold knife, which can be used to break these fibers completely. make the fibroid pop out, and something like a laparoscopic myomectomy, wherein the fibroids are actually, like enucleated. As you see the end picture out here, what was inside the cavity has completely come out, and then this can be treated like any cavitary fibroid, and the resection can be done very smoothly. Now obviously, we with time we have had newer modalities, and this is something which I find very useful, albeit it is expensive, are these hysteroscopic tissue retrieval systems. There is the IBS, there is the TrueClear, which is available. And this is something I have started doing a lot in my practice. However, one has to take it with a pinch of salt, because the initiation part, or the initial part of the shaving or the resection with these morcellators, sometimes feels like you're going nowhere. Like it just keeps moving without any effect. But trust me, it is slowly and steadily biting into this tissue. And the another aspect is the blade or the handle of the morcellator itself can be wedged in between the plane or the cleavage plane. And once you go beneath the fibroid, that is when the speed kicks in, and you can, like very safely. If you see the endometrial cavity out here, even though there is a defect which is seen, it is so beautifully preserved with no thermal damage whatsoever to the uterine cavity. Now, again, one important innovation is, since I'm a big user of the IBS, I really like that system, because it does not it just doesn't allow me to use the morcellator. It allows me to use the conventional operating channel, use it as an operating channel with these really sturdy instruments of 4 millimeters. So this is the hysteroscopic morcellator, which is morcellating the top part. And if you see this fibroid, once it is almost out, I can, like just go in with a grasper, catch hold of it, and take it out. So that's a sturdy grasper. It almost looks as big as the laparoscopic instrument, because the outer caliber is 4 mm, and it tapers inside. Again, another example, initially you will get this rocky feeling wherein you feel that nothing is happening. So this is what I was talking about. You can use it to wedge in between the fibroid and the endometrial cavity, and enucleate this fibroid. At certain point, if I feel that it's not happening, I can convert it, use a scissor, which I will be doing in this case. So like a laparoscopic myomectomy, like I'm using divergent forces with the scissors to enucleate this fibroid out. And at one stage wherein I feel it is completely separated, I can catch hold with a grasper and just rotate it so that it gets separated from the endometrial cavity. But what I want to highlight is the role of endometrium preservation. And that is wherein I'm one of the few surgeons who has downgraded. Like earlier, I used to feel that I'll be called a good hysteroscopic surgeon if I do a 9 centimeter or an 8 centimeter myoma hysteroscopically, because I've seen many of the seniors who do it beautifully, have done very challenging and big size, but I feel it does not do justice to the endometrium. Like rather than spending about 45 minutes risking fluid overload, this is the approach which I now resort to if there is any fibroid which is more than 6 centimeter, even though it is massively intracavitary. I would like to approach it laparoscopically, because what happens with laparoscopic removal, at one point there will be a giveaway, but there will be no thermal damage on the endometrium as such. If you see the yellowish part was the cavitary part. Okay, I will just, so that's where the cavity has opened up. And that part which I just highlighted out here, this one. Uh, so this yellow part was what was bulging into the cavity, and this was the part which was actually in the myometrium. And obviously, when one sees this, like it feels very tempting to resect it hysteroscopically. But that is when probably, like you are not doing justice to the fertility of the women, not taking into account the thermal damage that such a massive resection can do. You don't need to suture this endometrial cavity. What I'm just doing is there is always a layer of this myohyperplasia on top of the place where the cavity has opened. So that is approximated, and then a layered closure, as I've already showcased in previous videos, is done to achieve the hemostasis. Now, coming to the other pathology that we deal with, and I feel it's one of the most nightmarish pathology, is adenomyosis. And it seems innocuous, like it feels as if you're taming a cat, but you're actually dealing with a lion. And it's one such procedure or, like surgery, which feels very less rewarding, as even if you do a good adenomyomectomy, we cannot completely, remove the adenomyoma. So we'll have to do a targeted removal, wherein probably, we think of removing, like, say, taking off, like, say, 60 to 70% of it. If you're lucky, you might go up to 80 to 90%. Then reconstruction becomes a challenge if you resect more or excise more. And despite removal, you see these adenomyosis coming back with vengeance. So if you have a picture like this, okay, wherein the cavity was purely absolutely normal, like not too much of dysfunction in the cavity, and this was a diffusely enlarged or a diffuse adenomyotic uterus, which was almost 12 to 14 weeks. The best thing you can do out here the best thing you can do out here is to not touch these kind of cases, like not operate, and would probably put on a adenomyosis shrinkage protocol by using GnRH and planning a IVF for such patients. Now, where it has a benefit is something like this, wherein it is a focal adenomyosis. And yes, here is the role of an adenomyomectomy. There are various techniques which are available so that you can reconstruct these defects well. There is the triple flap technique, there is the four petal or the bloom technique, which Mala madam does. I personally still resort to this wedge resection. I feel I can be a little bit more controlled, and like sometimes when I try to flap, it gives me very thin flaps. And even though I, double breast it or triple breast it, uh, I don't feel very comfortable with the thickness or this thing that it gives me. So once it is done, once the adenomyoma is removed, now these are tricky situations, like because I have burned my fingers wherein I ambitiously have excised much more than I could put back also. So sometimes suturing these defects can be a real challenge. And many of the times the tissues are so friable that when you use a barb suture and try to do a layered closure, it just keeps cutting through the tissue, and it might not be feasible. So this is some instances wherein I might use deep box stitches and still do a conventional monolayered suturing, and then the retrieval is done. Now, yes, there is certain situations wherein we might be lucky and we might see an adenomyoma or like a focal defect, which is while resecting. So more often than not, like I would say, rather than a plan, this was a surprise for me as well, wherein I was hoping that I was seeing some defect in the endometrium in the transvaginal ultrasound. And I started with the resection. And for a moment, uh, when I'm resecting out here, in a moment, you will see that I felt almost as if I've perforated the uterus. I felt, oh God, what has happened? But that is not a perforation, because otherwise I would not be seeing such a distended view. So this was like a pocketed adenomyosis, which was seen. And this is where resection may sometimes help. However, routine resection of adenomyosis is obviously a no-no, because as we all know, it stems from the disturbance in the junctional zone, and it goes against the principle. If we are, like actually resecting, we are going to flare up and cause more adenomyosis. This was a lucky situation, and I'll show you what we were seeing on the ultrasound. This was the pocketed collection which was seen in the uterus, and we were lucky that we could access this with hysteroscopy. Uh, a little bit about the recent kid on the block, which is microwave ablation, which people are using left, right, and center for adenomyosis. I think its role is justified for recurrent adenomyosis, because the fertility impact, or how much is the ablation which is actually happening, is still very questionable. and sometimes we might in fact be hampering fertility by cooking or doing this microwave ablation rather than having a fertility benefit. So if any patient is desirous of fertility, I would still wait for it to be tested further. Now coming to the other pathologies, uh, I believe I have time, right? Can someone tell me how much time do I have?
Actually, Dr. Somil, we should be winding up in about 5 minutes because
Okay.
30 minutes are already up.
I'll just quickly go through this.
Sure, sure.
So some of the congenital defects that we know of are, as we know, the septate uterus, the T-shape, the bicornuate, and the acquired issues. Now, this classification, howsoever glamorous it might seem, I sometimes really wonder what clinical benefit it has done in my practice. It's a very beautiful looking classification. I mean, for me, it's enough, like that it's a septate uterus, it's a biconjugate uterus. So I find this classification very confusing. Now, these are some of the situations wherein I'll just go stepwise. Now, when we talk about a septate uterus, again, just focusing on some principles uh, from various studies, which have cited benefit of doing a septum resection, we are now moving back uh, and reanalyzing, whether a septum resection is actually justified or whether it has any fertility benefit. I mean, definitely, I would say just an incidental finding of a septum does not deserve a resection or a incision. Uh, but I am not very comfortable with the prospect of seeing a septum. And, if it is like, say, less than a centimeter, yes, probably it might not impact fertility. But uh, I mean, I think, as I said, our goal should not be just fixated on one point, that is conception or pregnancy, achieving pregnancy. It has to also look into whether doing some procedure is going to help long term as far as pregnancy is concerned. And again, this I am especially highlighting because there is a lot of itch in shifting to the scissors and minimizing the use of energy in cases of septum. And I completely side with that, that as much as possible, we minimize any thermal energy inside. But for these broad septums, it is really difficult to sometimes use the scissors. What is important is two, three things when we are dealing with energy is that one has to use the minimum effective current. So that amounts to, with a good ESU, it is somewhere around 40 watts pure cutting. And I am still someone who is old school and uses a lot of monopolar with the resectoscopic surgery. What is important is to minimize the contact time with the endometrium. You cannot be playing and activating it for a long time. Again, the T-shaped uterus, as I said, is another very abused surgery, like a lateral metroplasty. And this is where this classification, the Cume group, had come up with a consensus wherein all these three criterias have to be fulfilled if you're planning a lateral metroplasty, wherein they looked at the T angle, they looked at the thickness, and they looked at this angle, which if all the three are justified, it is when we do something like a lateral metroplasty. And as I'm highlighting, it's more energy definitely can have its drawback, but when used correctly, uh, I don't see it, undermining fertility, because for years and years, I've seen generations using it. I have myself used it. Uh, Now, where the problem occurs is if the cautery settings are, instead of 40, are kept at, like, say, a higher setting, like say 60, 80. And that is where myomectomy becomes dangerous, because a 40-watt current will not cut through the fibroid. You might have to increase the current settings to 80 to 100. That is where the damage occurs. Now, the lateral metroplasty, I don't know if you saw the initial HSG picture out here, but we are going step by step, millimeter by millimeter. And the endpoint is usually to a point wherein from the internal os, we are seeing both the osteas. Uh, again, there are few subtle signs wherein we start seeing this pinkish hue. Another very, tempting is this fundal incision, even though I have done it in this situation, but don't incise a normal looking, like these serrations or these things which you see are normal, like this itch to probably, like take this fundal incision and widen the cavity should be should be used with extreme caution. Now, this is the residual picture, and I would like to show you the HSG. So this was the HSG which was showing this type of a cavity, and that is what, like we have corrected out here. This was the original HSG picture, and this is the room that this procedure has created. Uh, I'll just go to my conclusion because I think I'm running out of time due to the want of time. I wouldn't want to overshoot. Uh, just in a nutshell, I want to summarize that when we are dealing with intrauterine pathology and uterine factors and fertility enhancing uterine surgeries, it has to be purpose driven. It cannot be passion driven. Like see pathology, treat pathology approach is not something, as mentioned by Sudha Madam and so many of our esteemed dignitaries, we have to use a patient centric approach rather than a pathology centric. One must remember that we have spent 9 valuable months of our life, like which were hostility free, tension free in this pious place of the uterine cavity. Handle it with extreme tender loving care. Energy, when used correctly, can definitely energize fertility, but misuse of energy is when problem occurs. And our goal at the end of the day has to always be to optimize surgical techniques and choices with fertility enhancing and endometrium preserving strategies. So at the end, I would just like to conclude by saying that the hallmark of a good surgeon obviously is knowing when to operate. That of a great surgeon is knowing how to operate. But that of the best is knowing when not to operate. So with that, I would like to thank all of you. Thank you again, Monica Madam, Randhir Sir, Asha Madam, all the esteemed dignitaries. Wishing you all the very best for your upcoming elections. And we are always with you to support you. Thank you. Thank you so much for a patient hearing. And if there are any questions, I'll be happy to take.
Yeah. Thank you, Somil, for that very elaborate discussion on problems for fertility, especially in dealing with the on fibroids. You showed us lovely videos, laparoscopy and hysteroscopy, and especially I think you pointed out what not to do. That is also very, very important. And any other questions from the audience? We'll take it now.
Beautiful presentation, Dr. Saumil, with excellent videos. So basically, you have highlighted the uterine factors very nicely, how it enhances the fertility once it is tackled properly. The crux is mainly the basalis of the endometrium, which we have to keep in mind, especially in case of submucosal fibroid. Of course, as you have said, hysteroscopic myomectomy is a commonly performed procedure, but then we need to know how to perform it so that it enhances and not deters and results in Asherman's. So for which I think in certain situation when it has to enhance the fertility, it is a good option to go laparoscopically as well, especially when you have a plethora of fibroids or when you have a huge fibroid where you do not want to damage the entire basalis. So I think this needs to be kept in mind when you are dealing with fertility patients. And of course, all other things have been highlighted very well. Only one video of yours I was thinking where you are showing the focal adenomyosis where you have resected hysteroscopically. I was also wondering whether that could be a Robert's uterus, because that once you just shave off that bit of the septum, you have a nice cavity behind it. It could be an oblique septum, could be also like a part of the Robert's uterus, is what I was thinking.
It was banked posteriorly. That was the only thing which I felt, like there was no rotation of the uterine cavity. So it was not seeming like an oblique septum. In fact, due to the paucity of time, there was one video which I had nicely presented in one of the AICOGs with a very difficult title. Like difficult title was hysteroscopic unification of non-communicating rudimentary horn. That was a time wherein I didn't know there was an entity called as Robert's uterus. So this was way back in 2016. So, like I had given such a elaborate title, and then someone from the chairperson told me, "My dear, this is Robert's uterus."
Robert.
So that is when I actually, like stumbled upon. But, madam, I have seen a few cases and managed also, but this was seeming unlikely. It was seeming more like a myometrial cyst. Like which was seen on the, and as I said, like there was something suspicious which was going out, and just by the judgment of the ultrasound, I started resecting. I for a moment also thought it was like a degenerated or a cystic fibroid. So I thought, let me just resect it. And this was like a surprise finding, rather, it was more like an incidental finding in this situation. So
Yeah.
as I
Soumya,
mentioned, I don't recommend that someone should resect adenomyoma hysteroscopically. This was just a chance finding.
Yeah.
there's just one question. Should we take it? Or there's a presence of myometrial cysts near the endometrium. How do you want to manage it?
So as I said, so many of the times the presence of the myometrial cyst can be a subtle sign, like of underlying early adenomyosis. So I think if there is a cyst, you don't need to do anything about it. You don't need to resect it or do any mischief with it.
Yeah, I think another thing is the most important structure what one needs to preserve while doing a myomectomy is preserve the pseudocapsule. Be it a laparoscopic myomectomy or a hysteroscopic myomectomy, preserve the pseudocapsule, which is very, very good. Like it is like a double-edged weapon. When it is with the fibroid, it is anti-fertility, but once you remove fibroid, it is pro-fertility. So it enhances the healing and helps in the fertility of the women. So that is one structure when it comes to fertility surgery. I think we all of us have to keep it in mind.
Right.
Thanks to all of you. I mean, it is such a feast listening to all renowned endoscopists of the country. And Dr. Somil, your videos were a real treat. The chairperson's inputs have been tremendous. And I thank you for the first session. I'm sure, Garima, that your idea of keeping endoscopy as a part of perfection was truly, a very good idea. And we have to have a part two very soon. So now I take the privilege and honor to invite amongst us President ISAR. Dr. Amit Patki has joined us. Welcome, Amit sir.
Yeah, Monica, hi, this is Dr. Ganatra. I will have to rush for another
Yes,
surgery.
sir. Okay, sir. So we will now introduce and welcome our chief guest for today evening. Dr. Atul Ganatra is amongst us, and sir has been President IAG 2024 to 25. Many important posts in
Don't bother, Monica. It's okay.
yes, and we recently had the privilege of hosting him in Bhopal. We know him as a very dynamic speaker, academician, surgeon. Sir, the stage is all yours, and we are waiting for your speech.
No, no, no. I don't want to give any speech. Congratulations for a wonderful event. Garima, Damodar, they're all family. Pratik, what are you doing with a stethoscope यार? तू कभी stethoscope लगा के बैठता है patient के साथ में?
कभी कभी पेशेंट भी देखना पड़ता है सर.
अच्छा ऐसा है क्या? ठीक है. And Saumil, Mala, lovely presentation. I just heard Saumil's presentation. And please go ahead and take Dr. Amit Patki.
Thank you.
And all the best, Monica. Thank you.
Thank you, Atul sir, for joining and being here. And Amit Patki sir is with us. Sir, I was saying that 5 p.m. you had the e-vote meeting, and
Yeah,
that started palpitations for all of us.
it was a mock drill for the election.
Yes, sir. So, sir, we are so privileged and honored to have President Isar amongst us. He has taken the organization through many dimensions and recently concluded a very important management program in IIM Ahmedabad, which was something totally innovative, totally something out of the box. So, which made us thinking that even doctors, surgeons, gynecologists need to have some ideas about management if they have to be successful professionally. So the stage is all yours. Kindly provide your blessings to us and our program.
Thank you very much, Dr. Monica, and a very good evening to you all. At the onset, I must congratulate Monica and Randir for successfully running this Perfection series for the last so many years. And I think just one phone call 2 years back, and she willingly continued. So thank you, Monica and Randir, for doing this superb series where you all bring in innovative topics and excellent speakers. And I think it is very, very enriching to listen to all of them. Yes, ISAR has done well, and in the last 2 years, we have done multiple webinars and master classes. But as you said, that IIM Ahmedabad masterclass was really a dream come true for me because I had missed it around 7 years back when I'd enrolled for the executive leadership. So I thought, why not do it for fellow ISARians? But believe me, I've made more enemies because of that masterclass than friends, because I had a barrage of SMSs asking why you did not think of me. But frankly, we are going to repeat it again in another 4 5 months time. So I will consider all those who had WhatsApped and messaged me saying that they want to be part, and we'll ensure that we include all or either most of you in the next course. But believe me, it's an eye opener. It really changed my outlook towards thinking like why doctors should advertise and how we can ethically go forward and do digital marketing, especially in this day of AI. So coming back to this webinar, I was enthralled watching Sawmill's videos. So Sawmill, hearty congratulations. I think excellent videos, and I'm looking forward to listening to Pratik and then to the panel discussion. So thank you very much, Monica and Randir. Best wishes to all of you. I'm sure you all have worked so hard. So I'm sure people will vote for you, and I'm looking forward to good people coming into ISAR and taking it to much higher levels. As always, it's a pleasure to watch Atul, Sudha, and Dr. Pandit Palashkar. So thank you so much for all these stalwarts who have joined, and looking forward to the rest of the program. Thank you so much.
Thank you, Amit sir. Thank you. Thank you. Asha Bakshi ma'am, and we were discussing that the percentage of voting, the true democracy is when the large percentage of voting comes. So she told no that we send the reminders to everyone. And I think under your leadership, the ISAR is going a great, and this flag will continue. Thanks, sir.
Thank you so much. And this is a record number of people who have filed in for their ISAR
Yes, sir.
election.
Yes, that's
So
good, sir.
I'm actually very happy that people are wanting now to come into ISAR, and I'm sure the best people, and even those who do not get elected, I'm sure they will have an opportunity to work and maybe try again next year. Thank you.
Thank you, sir. Thank you.
Yes, sir. We saw in your tenure as president, which is still continuing, that many people who were just working but not exactly in the managing committee were equally represented. So this is the beauty of Sir's tenure, that he has given, opportunity to every Isarian, and we have seen the tremendous way the list has grown. When I fought my first elections in Isar, the list was something a little above 4,000, and now we have close to 6,700 members, which is like phenomenal. And Garima, I think you are there smiling quietly. You know how you have given that, that offer of discounted membership to so many people. Purva here is sitting. I made her a member. That you are the coordinator, you have to become the member. So thank you all very much. And now, with blessings of our president and chief guests, we move to session
Ma'am,
two.
I'll just take 2 minutes here since Patki sir is also here.
Sure,
We
sure.
have our third drive, which is already ongoing for the ISAR membership. I would request all of you to encourage your fellow young doctors and your embryologists also to take the opportunity of this third successful ISAR membership drive. Thank you, Amit sir, for giving us this opportunity.
So, who is doing session two? Garima?
Ma'am, I'm
Yeah,
I'm
yeah,
doing. Yeah.
yeah. Purva, please start the session two. Dr.
Yes,
Pratik.
ma'am.
Yeah.
Yes, ma'am. So moving to our next session, that is on obesity and human reproduction, we invite speaker Dr. Pratik Tambe sir. To chair the session, we have Dr. Srinivas sir with us, Dr. Randhir Singh sir, Dr. N.C. Chimote sir, Dr. Anuradha Kar, ma'am. Dr. M.S. Srinivas sir. Sir is Director and Principal Embryologist of Career Fertility Private Limited. He is Founder President of ACE India, and he is a very active member, State Board member of ART Surrogacy Act 2021. Sir is Course Director of MSc in ART and Chairperson ISAR Embryology. Past President Karnataka Chapter ISAR. We welcome you, sir, to chair the session.
Namaste.
Namaste. Next, we have our own Dr. Randhir Singh, sir. Sir is Director and Head of Embryology, Bhopal Fertility Endoscopy Surrogacy Center in ART Bank. He is presently Managing Committee member ISAR. He is member of Madhya Pradesh PCPNDT Board, member Madhya Pradesh ART Surrogacy Board, founder executive member ICRM, and he is also professor in Ellen Medical College, JK Hospital, Bhopal. We welcome you, sir. Next, we have NC Chimote, sir. Sir is a managing director and founder of Vasundhara Fertility Center with more than experience of more than 3 decades. We welcome you, sir. Next, we have Dr. Anuradha Kar, ma'am. Madam is presently Director of Nurture IVF Bangalore. She is very senior consultant in Bangalore city, and she is Treasurer of Karnataka Chapter of ISAR, Member Managing Committee ISAR, and she has published various chapters in various books and a recipient of Foxy Badlav Award 2024. We welcome you, ma'am. Now I hand over session to Chairperson to introduce our speaker, Dr. Pratik Tambe, sir.
Thank you, Dr. Purva. Thank you, my other chairpersons. So I think Pratik Tambe is the well-known person, and I think he's the what I'll tell you the roots, the true roots of the ISAR, because I have seen him working since 20 years, all ISAR presidents past, and so. But it's my job and honor to introduce my good friend. He is a director and the consultant in Ashirwad IVF Mumbai. He has trained many persons, and he himself is trained in the Belgium, then clinical embryology in the London and the Singapore. He is very, very active in ICOG. He has taken a lot of all the important key posts. If I'll enumerate, it will take half an hour. But what I'll see the key post is that recipient of the 36 MOGS ISAR Foxy and awards, edited more than around 50 books and chapters, contributed 100 chapters, and he has been the convener ICOG reproductive medicine. I have told you 21 to 25, and he's a peer review in all the journal. So, and he's the best. He got awarded as the Don Prize ICOG, and so he has got MOGS and a
Thank you,
Purandare
sir. I think
Prize
that should
and the
be enough.
ICOG
I
CG
think that's
Satya
enough.
Prize. So the
Thank you.
platform is
Thank you.
yours, my dear.
Thank you. Thank you very much, Dr. Monica Singh, Dr. Randhir Singh, and thank you, Isar, for this opportunity. My
And
greetings
Dr.
to
Pratik,
everybody present.
our heartiest congratulations for you, because you will be officially taking over as Secretary of Indian College of Obstetricians and Gynecologists in the forthcoming AICOG at Delhi. So
Thank you
congratulations.
very much. Thank you for all your blessings, support. I cordially invite all of you on 17th of January in the post-lunch session when the ICOG convocation will be held. And as Atul was saying just now, occasionally I do practice medicine as well, besides doing lecture. But today I'm here to speak about obesity and human reproduction. And this is a topic which has exploded in not only medical circles, but also in layperson's imagination over the past couple of years. Because of a lot of new medications which have been introduced into the market, a lot of laypersons have also been feeling post-COVID pandemic that they have gained weight, and you know how it snowballs. Let's start, and I have very little time to cover this difficult topic, so I'll try and focus and be as evidence-based as possible. Any fool can know. The point is to understand. Let's try and understand what obesity does to human reproduction and what human reproduction does to obesity. This issue is obviously irrelevant to current practice. We've already said that in the beginning. These are old figures from WHO. They're pre-pandemic, but they are an eye-opener figure. because WHO says that worldwide obesity has tripled since 1975. Nearly 700 million were obese or overweight. That's approximately a population of 50% of all human beings worldwide. And if you fast forward to today, 2025, it is estimated that in the US alone, almost 70% of all adults are either overweight or they are obese. Millions of children under the age of 5 are also overweight, and there are multiple studies which say that adolescents have been increasing in weight and girth by leaps and bounds. Most of the world's population now lives in countries where overweight and obesity is unfortunately killing more people than underweight, which is a complete 360-degree somersault, or should I say 180-degree somersault, because 360 means you'll come back to the same spot. Compared to when we were in the 70s and 80s, struggling to eke out a basic existence, and we were trying to fight maternal mortality, infant mortality, that conversation seems to have shifted radically, especially in the past couple of decades. We know that there are multiple medical conditions which are associated with obesity because this is a major risk factor for several non-communicable diseases, including cardiovascular issues, diabetes, musculoskeletal disorders, and certain types of cancer. Obviously, these are something which are going to happen long term, and therefore, the vast majority of us, doctors included, and yours truly included, to be very humble and to the point, we don't really consider this as a major issue. We consider this, in fact, in our country, a sign of prosperity, a sign of doing well, affluence, like you're healthy. Literally, the term is that you are healthy. And I don't know where that terminology came from. When we look at the consequences of childhood obesity, it is well documented, and this is from WHO, that you have a higher chance of premature death, disability in adulthood, difficulty in breathing, fractures, hypertension, cardiovascular disease, insulin resistance, psychological effects, and of course, the Barker hypothesis. We will come to that a little later. On to the topic of the day and whether fertility is an issue in couples who are obese. The overwhelming answer is, of course, yes. But when we examine literature and we see all the major publications in this area, there are several landmark papers which stand out. And all of these are freely available on the internet. You do a PubMed search or you do a simple Google search, these will come up. They are not hidden behind a paywall. You can download them, easily find them, and you will see exactly where I'm coming from. If you can't find them, write to me. I'll be happy to share a copy with you by email. The elephant in the room is the ASR in Practice Committee recommendations on obesity and reproduction, which came out in 2021, published in Portal Sterile. FIGO also came out with a lovely position paper on the challenges of obesity, and you'll see several familiar names in this particular publication, including Nikhil Purandare, Edgar Mocano, our very own Jaideep Malhotra. And this is from the two FIGO committees, Impact of Pregnancy on Long-Term Health, and also the FIGO Committee on Reproductive Medicine, Endocrinology, and Infertility. This is one of the newest papers by FIGO and was published in Jan of 2023. Obesity is a well-known disruptor of both male as well as female fertility. We'll be talking about male infertility a little later, but primarily I want to focus on female fertility and how it impacts the reproductive endocrinology of the woman when she is obese. So what are the implications for fertility? Obesity has adverse effects on ovulation, menstrual function, natural fertility and fecundity rates, infertility treatment success rates, of course, which is what the main focus of this talk is going to be, the safety as well as the obstetric outcomes later on when these women get pregnant. I have just kept this slide for reasons of posterity because these are WHO classification and this has to be part and parcel of any half an hour talk on obesity. But these are not applicable in India. India cutoffs are different and these have been defined in the ISAR guideline, and I will be speaking about that a little later. So this is just for your memory. Indian cutoffs are a little different and we will come to those in due course of time. You might remember this gentleman, the French barber surgeon Ambroise Paré, who described women with increased weight, amenorrhea, and hyperandrogenism first in 1633. And of course, Stein Leventhal took this further and described polycystic ovarian syndrome and wedge resection a couple of years later. When we talk about the basic reproductive endocrinology and the menstrual cycle, you will not be surprised to know that every single aspect of the menstrual cycle is completely distorted by obesity and overweight. And this has been reported in a wonderful study called the Study of Women's Health Across the Nation, or the SWAN study, which was published in 2010 in Fertile Sterile. And they said that amenorrhea or oligomenorrhea increases with increased weight as well as obesity in childhood and adolescent. If you have a child who is obese at the age of 7 years, this is an independent predictor of menstrual problems by the age of 33 years. And they looked at a meta-analysis of nearly 1.5 million treatment cycles, that's ART cycles, and they found that there was a negative impact of BMI on ART success rates. This is probably the most important slide in the entire presentation, and this is actually a slide which I use to counsel my own patients. So if you want, you can take a screenshot of this. And this actually lists out very clearly how BMI and anovulatory infertility are correlated with each other. If you have a BMI of 20 to 22, then your baseline fertility is taken as 1. And if you just move off 2 or 3 points, 25 or 26, you can see straight away the relative risk of infertility goes up by leaps and bounds. If these figures are not very convincing, I have another graph, and this is one of the oldest graph actually. This is a study from 1994 by Rich and Edwards, and I have used this for the longest possible time. I think nearly 20, 25 years I've been using this same slide to talk to my patients and show them how, with just a slight increase in your BMI, your risk of infertility increases manifold. This is in mathematics called something called as a geometric or a logarithmic progression, for those of you who are interested in math, but that's not the vast majority of the audience here. I'm not going to bore you by talking about two-cell to gonadotropin theory because my audience is primarily fertility consultants and practicing OBGYNs. But what I want to emphasize is that there is an altered endocrine profile in obese women. These women, even if they are ovulating naturally, but if they are obese, will show you a lower total cycle FSH as well as LH. There is decrease in the early follicular phase FSH as well as LH pulse amplitude. There are longer follicular phases, shorter luteal phases, and of course, decrease in the endogenous luteal phase progesterone. All of which gives you a perfect storm and multiple reasons why these women can't conceive on their own. It is much beyond just anovulatory infertility. And if they do manage to ovulate with or without our assistance, then you can see how your success rates, your treatment success rates are going to be abysmal. There is a lot of altered physiology consequent to obesity, of course, and this is well known. This list is long, but it is not exhaustive. You know that obesity leads to insulin resistance and vice versa. There is a vicious cycle between the two. There is hyperandrogenemia, decreased SHBG, increased peripheral aromatization of the androgens to estrogen, and altered levels of leptin and adipokines. And we will talk about this a little bit. In fact, adipokines, leptin, all of these are being studied extensively for at least the past 5 to 10 years. And unfortunately, we still don't have a very good medication that tackles these leptins and adiponectins directly or indirectly. Hopefully, sometime during my lifetime, that does happen when we have better gene therapy and we can tackle these agents. We do have GLP-1, but if we had something which tackled the leptin and the adiponectin directly and we could treat leptin resistance, I think the vast majority of PCOS sufferers and obese women in the world would really thank us. Is there an altered ovarian response when we treat these women for infertility? The short answer is, of course, yes. Even in normogonadotropic women, we are not talking about PCOS women, women who have normal FSH LH, you will find that if they are obese, there is a change in the ovulation response, change in the response to oral ovulogens. When you administer gonadotropins to these women, they are going to require higher doses of medication and will obviously produce lesser number of follicles at any given dose. Even if you give them 75, 150, you may not get the standard responses which you would expect in a woman who is otherwise normogonadotropic. If you look at the duration of treatment, it's going to be longer. You're going to require greater consumption of ampules of FSH. Your total days of stimulation may be higher. There's going to be increase in cancellation rates, fewer number of oocytes retrieved, lesser number of metaphase 2 oocytes, and all your KPIs of key performance indicators of the embryology lab, which doubtless will be tackled later on during the panel, all of them are going to go haywire. Specifically, it has been studied when you look at the follicular fluid and the microenvironment, and obviously these are studies coming to us from Western countries because we don't do that in India. You have an altered follicular environment, you're going to have a higher amount of insulin in the follicular fluid. There are going to be greater elevated markers of inflammation, more reactive oxygen species, abnormal OCC complexes, smaller oocytes, dark cytoplasm. You know, my embryologist, whenever she says dark cytoplasm, the rest of my day is completely short because I know I'm not going to get a result in this cycle. And obviously, your progression to blastocyst is going to be less. After you've overcome all of these challenges and hurdles by using good quality gonadotropins, longer duration of stimulation, greater starting dose, adjuvant therapies, add-ons, every single trick in the book that we have learned, and why I've lost my hair and I've turned gray, I wouldn't say prematurely, you will realize that these women also have poor endometrial receptivity. And this is what we were talking about a little while ago. This is what we were alluding to. These women have an altered window of implantation. If you do the ERA testing, you will find that it's all over the place. Not that we would do ERA in such women anyway, but there is a greater chance of having aneuploid embryos. In the presence of euploid embryos, you're going to have a greater risk of miscarriage, and you're also going to have a greater incidence of embryo rejection, which is because of your poor endometrial receptor. How do we tackle the issue? Can we counsel our patients before beginning fertility treatment? And ASRM has a very nice picture here, which gives you a nice color coding. If the weight is green or it's yellow, you're perfectly fine. If it's orange or red, then you're in dangerous territory. And probably these women will benefit from serious medication or a good break with appropriate targeted therapy and a multidisciplinary team approach before you start fertility treatment in them. I've been saying this for about 10 years now, and I'm very happy that it's been taken up by many international organizations that the pre-pregnancy optimization of the woman's condition is of paramount importance so that you get good acceptable clinical pregnancy rates and your pregnancy actually reaches term, because the end result of your fertility treatment has to be a live singleton baby which you can take home. Just getting those two lines on a urine pregnancy test or demonstrating a blood beta HCG test which is positive doesn't mean you won the battle. You need a baby that goes home. That is how we should all finally be judged. When we look at the obstetric complications that occur in these women, again, there are plenty of meta-analyses and systematic reviews which show that hypertensive disorders, pregnancy, gestational diabetes, cesarean births, instrumental deliveries, LGA babies, FGR babies, NICU admissions, all of these are significantly higher in these women. Since we've talked extensively about female fertility, let's talk a little bit about male infertility as well. And you will not be surprised to know that even in male partners, when they are obese, there is a range of issues which is going to occur. And this is published in RBM Online in 2018. This is Jyotsna Pundir et al., who have said that there is a decline in the semen parameters. You're going to have OAT, obviously, but sexual dysfunction, including erectile dysfunction, is completely widespread now. I am seeing so many more patients of ED today as compared to 10 years ago. These male partners may have other issues like hypertension, diabetes, both of which are undiagnosed. They may have obstructive sleep apnea. And when you look at the semen parameters, they are going to have more oxidative stress, decreased mitochondrial activity, and sperm DNA damage, of course, if you do your PFI testing, which is something which we offer only in a certain select group of patients. All of this translates into decreased live birth rates. And we were just saying a couple of minutes back that finally we should be judged on our live birth rates. What does the evidence say regarding management approaches? You know the ESHRE guideline on PCOS. You don't need me to tell you about that. We need to counsel our patients that BMI is something which is an issue, and just 5% weight loss, especially in PCOS women, over a 6-month period can restore fertility and have spontaneous pregnancy. This has been proven by Robert Norman et al. 25 years back. This is a paper from BMJ way back in 2000, and they said that if you reduced your BMI, then you could increase your success rates by as much as 1.2. And If you fast forward to 2021, this has been proven again by a meta-analysis of 8 randomized trials, clinical pregnancy rate of 1.87 and a live birth rate of 2.2 if you were able to reduce weight in a systematic fashion. What are the management principles for obese women? Obviously, you need to have a multidisciplinary team approach. You need to look at cognitive behavior therapy, diet management, lifestyle modification. All of these are familiar buzzwords to all of you. So I'm skipping past some of these boring slides and I'm going to go straight to what is new. Carrying more weight and obesity does have long-term complications. All of this is known to you. Long-term consequences of PCOS and long-term consequences of obesity actually go hand in hand. So multiple NCDs. And the best marker that WHO and several international authorities have found for predicting long-term complications is actually not BMI. You'll be surprised, and this is a landmark paper published in JAMA in 2023, which looked at nearly 400,000 subjects over 17 years, and they found that the humble waist hip ratio actually equates with mortality and long term complications much better than your BMI. And these are the curves to prove it. The long term consequences, we also know about the Barker hypothesis, which we briefly mentioned at the beginning of the talk. If there is maternal obesity and there are epigenetic changes, a girl that is born to an obese woman is going to carry certain changes and they're going to be passed down to the next generation and result in complications in that child as well. The tools for long-term success are behavioral modification strategies, self-monitoring, journaling, diary, and there are these beautiful instruments which we are slaves to. You can't see it because it's black and my background is also black, but these are mobile phones and you have excellent tracker apps and journaling apps which are now available so you can use them to document your journey and improve your success rates. Figo says that there is minimal literature on the direct effect of lifestyle modification on fertility, but there is positive changes that happens if the weight loss is maintained. Medications for weight loss have shown promising effects on fertility, and bariatric surgery has been shown to improve patients' cardiovascular and metabolic risk profile. Since we're talking about bariatric surgery, there are a number of surgeries which have been proposed. There are about half a dozen which are practically actually used in clinical practice. And these are to be restricted to a certain age group and a certain subset of patients, which I'm coming to in the next slide. So these international guidelines for obesity have been published in 2024. We all know about Ozempic. I didn't want to talk about Ozempic and Wegovy today because that's a half an hour, 45-minute talk by itself. I will quickly summarize by saying that they offer a great opportunity to simultaneously treat body weight, insulin resistance, cardiovascular issues, and if she's concurrently diabetic, of course, then they are the best things in sliced bread. We did a nice consensus on obesity management at ISAR, and this has been published in 2024. I was fortunate enough to be part of the group. Dr. Mepatki, Dr. Nalita Palchakar, Dr. Rishikesh Pai were all there. And I actually worked on this algorithm which is documented in that paper. Again, this is freely available on the internet. If you can't find it, write to me, I'll send it to you. So what we do is step one is to look at the anthropometric assessment and look at the comorbidities that the woman has. You measure your BMI, do your waist hip ratio, and then look at comorbidities like fibroids, incontinence, hypertension, diabetes, dyslipidemia, all those weird NAFLD, etc., etc. Step two is to look at the risk stratification. If your BMI is more than 23 and or the waist circumference is more than 80, which by definition is 90% of the patients, 95% of the patients who come to us in practice, because those are the women who are not able to conceive. I don't think you would get anybody who doesn't fall into those criteria. And then you grade your obesity. And these are the Indian cutoffs, which are validated by several population studies. If your BMI is between 23 to 24.9, you are overweight. Class 1 is when the BMI is between 25 to 29.9. Class 2 is when the BMI is between 30 to 34.5. And class 3 is when the BMI is more than 35. So these are the Indian cutoffs. These are validated by several population studies, and we have reproduced them in our guideline as well. Step 3 is diet and exercise. And those patients who don't respond to this, then you're supposed supposed to start with medical management. If the BMI is more than 27 and there is at least one comorbidity, or if the BMI is more than 30 with or without comorbidities, then you can offer weight loss drugs. And the currently approved drugs in India, of course, are orlistat and semaglutide. And also we have tirzepatide, which has joined the party very recently. Surgical management is only recommended if BMI is more than 35 with or without comorbidities. And these are the patients who are going to benefit from your multidisciplinary team approach, endocrinologist, obesity consultant, and so on and so forth. Okay. If you find that there is not greater than 5% weight loss at the end of 3 months, you're supposed to take a step back, reassess, and go back into your multidisciplinary team approach. There are special considerations for women, specifically who have PCOS, who have pregnancy, postpartum, postmenopause, etc. We will not go into that today because we are primarily concerned with women who have infertility issues. So to conclude, ladies and gentlemen, obesity is the hidden pandemic. We need to tackle this. We need to try and nip it in the bud wherever possible. Pre-pregnancy optimization and pre-cycle optimization are the two key practice points that I want to push forward today on this ISAR platform. And if each and every one of us tries to ensure the pre-cycle optimization of both partners, you will not only see better clinical pregnancy rates, but you will also see it reflected in lesser complications during pregnancy and ensure that that baby goes home. Thank you for a patient hearing. Prevention is one always better than cure. Thank you,
Chairpersons.
Dr. Monica Singh. Thank you, Isar, for this opportunity. I had to rush through a little bit because we were running late. I hope I've done justice to the talk.
You have thoroughly done justice to the talk. Chairpersons, Dr. Anuradha Khar, my dear friend. You're muted. Please unmute, Anu.
Good evening, everyone. Thank you so much, Dr. Monica, for inviting me. And thank you, Dr. Pradeep. Always you are so academically good, and I love to listen to your lectures. And this talk was wonderful. And obesity is something we handle it like 50% of our cases. What we handle on a daily basis is obesity. Now, I would like to ask you one question.
Yes.
With this Manjaro gaining so much popularity, what is your take on that?
So as I said, if you are working in infertility practice, you have to be guided by evidence, and you should be trying to optimize the pre-pregnancy and pre-cycle status of the woman with diet, with exercise. If she falls into the criteria for starting weight loss medications as per the ESAR guideline, which is published in 2024, then by all means, but remember to counsel your patient that she is not supposed to conceive while she's on the medication. She needs to take a break for at least a couple of months before she thinks of pregnancy after that.
What about
there was a
rebound obesity after stopping GLP-1 receptor agonist? There incidence of rebound weight gain? And how
there will be incidence of rebound weight gain, but that will typically happen 3 to 6 months later. And by that time, your woman should have conceived. If you are any good at our fertility treatments, that is.
Yeah, because I was
so
Anu, please go ahead.
Recently, I read one paper. I mean, it was more in the news rather the scholarly article that, of course, Ozempic is facing a lot of litigations, the company, pharma company. But there was a small line about, there was a small line even about Manjaro that they have seen rise in mental illnesses with these medications, and even suicidal thoughts are increasing. So this is a recent paper
Suicidal
I read.
ideation, mental health issues, and ophthalmic artery occlusion, which is irreversible.
Blindness more in the Ozempic group, but even Manjaro.
These are the 2 or 3 which have been mentioned. Yeah.
So, what do we do with such cases? Of course, one is counseling, and I mean, you have to counsel a patient. Where do we stand in the court of law? Somebody actually commits a suicide, because there is
So
severe
the law
suicidal
is very
tendency.
clear. The law is very clear. If there is an evidence-based guideline, if there is a national guideline, if there is an indication, if there is a shared decision making, if you've documented that you've counseled the patient and then only started, you had a multidisciplinary team approach where more than one person is saying that this medication is appropriate for them. You're on perfectly solid ground.
So we need to have a written consent for this drug. Does everybody agree on that we take a written consent on this drug when we start this, or just verbal consent is enough? And second, because the mental illness, suicidal tendencies are of severe, supposing they go severe in some patient, do you need a video consult or recording for such patients when we counsel them, Dr. Pratik?
What you would ideally do is that you would have a written, informed, documented consent, but you would also refer this patient to an allied specialist like an endocrinologist, like an obesity consultant. We have the luxury of having an obesity consultant in our major metro cities, but not everybody practicing in a tier two city or a small town would have access to somebody like that. But if you were to refer to a patient, refer this patient to an endocrinologist, they would also be a good enough alternative, I feel, if you didn't have access to an obesity consultant in your city.
Yeah. The second part of the question now is that, are we, as reproductive medicine specialists, authorized to write this drug medically, medico-legally? Are we
If there is an
authorized?
ISAR
Can we
guideline,
write?
if there is an ISAR guideline which says that you can prescribe semaglutide, your job is done.
Okay.
You know,
So thank you
NHS,
so much.
NHS has this as a first line drug. Anuradha, I had a patient, I had a girl coming from the UK. She was visiting her family for a month and she was on this drug, and she had lost about 12 kgs and developed a severe aversion to food. And she was feeling nausea every time she saw food. A protein intake had come down to bare minimum, so she stopped the GLP-1 receptor agonists, and she came to India. There she was not getting an ultrasound scan for the next 6 months. So
Ah,
we yeah so she was on this
So
drug,
was
and
she on subcutaneous?
no, she was taking a tablet.
she
She was
must be
taking a
on
tablet,
oral,
then probably
because
her dose
oral has
needs to
the
be reduced.
worst.
Yeah,
Yeah, the
so
Need to
gastrointestinal
reduce the
effects
dosage.
are bad with oral.
yeah, so then my sister, who's a GP and dermatologist in UK, she was with me a whole month. I asked her, and their NHS is giving it left and right, because obesity is so rampant there in
Yes.
first world countries. They have no clear guidelines for patient. They just give to the patient who wants to lose weight or who is a suspected PCO. Rather than really diagnosing PCO, they give this drug, GLP-1 receptor agonist.
Yeah.
So,
And
yeah.
but at the same time, Dr. Monica, the number of bariatric surgeries have come down. My one of my colleagues is a bariatric surgeon, and now their focus is shifting to these drugs, these injectables mainly, Monjaro and all the bariatric surgeons have started writing, because people prefer this to the surgery.
I mean, it is so
But
The
if you
attractive.
go
surgery
through
is
the
in
recent
waste.
literature published just a couple of weeks back, bariatric surgery is supposed to be more beneficial in terms of weight loss, sustained weight loss, lesser chance of side effects like mental health issues, which you were just mentioning. Of course, it carries with it the issue of malabsorption and regularization of the GI, which takes about 1 to 1.5 years.
So,
Again,
bariatric.
if we do that for infertile patients, there is a risk of even an IUGR baby later on. That we have to keep in
Yeah,
mind.
exactly. So that's why you
Pregnancy,
need to keep a gap of one
malabsorption
to one and a half years.
happens. Correct. So for probably for infertility patients, probably these injectable drugs are better, or tablets if they can, tolerate. Thank you so much.
Thank
Deficiencies
you,
are going
Dr.
to
Anuradha.
whether it's a bariatric surgery or it is a GLP-1 receptor agonist, the deficiencies are going to be there for micronutrients. So we have to counsel the patient both ways, but it is really very, very attractive option. People posting on Facebook, suddenly they lose 15 kilos. It's so, unrealistic, but it's happening, and
I wish
people are.
it were that simple, but it's not actually in practice.
So, Dr. Pratik, it's very, very, and you can just go from size, 12 to size 8 or 10. I mean, it's very
Yes,
attractive
yes.
option. But then, of course, you have to know, you're a doctor, you have to weigh all the pros and the cons. Thank you so much, Dr. Pratik. We
Thank
have
you.
kept you as the
Thank you,
star
Dr.
of.
Monica and Randhir. Wishing you all the very best for the elections. I'm sure you'll do well and you'll pass with flying colors.
Thank you, Dr. Pratik. All
Thank
my
you,
panelists
Dr.
are there.
Pratik.
All my panelists are right now here just because of you.
Thank you.
Otherwise, we wouldn't have had such a full screen. Thank you so much, Dr. Pratik. See you in Delhi very soon.
Thank you. All the very best.
Thank you.
Bye.
Thank you. Bye. So now let's start the panel. Purva and Payal are there. So let's
Yes,
start
ma'am.
the
Yes.
panel. Thank you, everyone, so much.
So,
Manisha, by the time the panel is getting ready, you would like to speak something? Manisha Bajpayee? Is she there?
yes,
She
ma'am, she
was.
was there. Mm.
So, since elections are going on and we all are SR members, and we have actually, I would like to do a small appeal to all the fellow viewers that please, elections are going on. So, please do vote. It means a lot to everyone of you to shape the future of our society. And three of our stalwarts and one of our very dear guests, they are contesting. Dr. Asha Bakshi ma'am, she is contesting for post of vice president. Then Dr. Monica Singh ma'am, she is contesting for managing committee member, clinician. Dr. Randhir Singh sir contesting for embryology, managing committee member, and dear Anuradha Khar ma'am is there as a managing committee member, clinician. So please do vote them and support all of them for shaping a beautiful academically inclined future for our society. Thank you. Thank you so much.
Thank you. Thank you, Manisha. Thank you for the nice words and wishes.
Thank you.
So let's start the panel now, girls. Yeah.
Yes, ma'am. Now moving to our very interesting panel discussion that is on troubleshooting in ART. To moderate the panel, we have our own Dr. Monica Singh ma'am, Dr. Padmaja Veera Machmani ma'am, Dr. Manisha Vajpayee ma'am, and experts we have Dr. Ruma Satvik ma'am and Dr. Viren Shah sir. We welcome you all. Now, first, we will introduce our moderators. Dr. Monica Singh, ma'am, is the convener of the program, and she is presently President-elect of
Okay.
Bhopal
So, okay.
Obligatory Society.
Okay, Purva, please go ahead.
Yes, ma'am.
The next moderator is Dr. Padmaja Veeram Chennani, ma'am. She is a very senior gynecologist and infertility expert from Vijayawada. She has various awards to her credit and has various professional recognitions to her credit. We welcome you, ma'am.
Thank you.
Next, we have Dr. Manisha Vajpayee, ma'am. Madam is presently head of the Department of Embryology and Research, Pacific Medical College, Udaipur. And she is presently Managing Committee Member ISAR, Executive Committee Member ACE. We welcome you, ma'am.
Now we have our first expert, Dr. Ruma Satvik, ma'am. She is a very senior consultant and professor reproductive medicine from Sir Gangaram Hospital, New Delhi, and has various publications to her credit. She has a special interest in certification from Stanford Online and Medical Statistics Program and in AI in Medicine. We welcome you, ma'am.
Next, we have Dr. Viren Shah, sir. Sir is presently director at Garaz IVF and HD Care Indore. He is the senior most embryologist of our country who is trained at Singapore, and he has delivered first IVF baby in our state. And he is attached to various IVF center, very active member of ISAR. We welcome you, sir.
Now we would like to introduce our panelists. So our first panelist for the session is Dr. Bhavika Gala. She is a clinical embryologist from Agra. We welcome you, Dr. Bhavika.
Next, we have Dr. Dharam Shah, sir. Sir is IVF Specialist Director at Mumbai Fertility Clinic and IVF Center, recipient of ISAR Youth Icon Award. We welcome you, sir.
Next, we have Dr. Fasina Sethi, ma'am. She's a very senior embryologist and she's currently practicing at Kochi. She's an ASHRAE certified senior embryologist. We welcome you, ma'am.
We have Dr. Gautam S. He is presently Deputy Lab Director and Senior Embryologist and Head Embryology Instructor at Academy of Clinical Embryology. We welcome you, sir.
Next, we have Dr. Gauri Sultan, ma'am. She's a fertility specialist from joining us from Mumbai. We welcome you, ma'am.
We have Dr. Jayashree Pathak, madam. Madam is a senior consultant and fertility IVF specialist at Cloud9 Fertility Center, Delhi. We welcome you, ma'am.
Next, we have Dr. Meeta Sharma, ma'am. She is also a very senior ASHRAE certified embryologist. We welcome you, ma'am. She is actually from Jaipur.
We have with us Dr. Monica Sharma, ma'am. Madam is presently Director and Chief Consultant Gynecologist, IVF Specialist and Laparoscopic Surgeon at Sparsh Mumbai Women Hospital, Rajasthan. We welcome you, ma'am.
Next, we have Dr. M.S. Gaur, sir. He is also a very senior embryologist from Ajmer. We welcome you, sir.
We have with us Dr. Neeti Bansal, madam. Madam is presently fertility specialist at Delhi. We welcome you, ma'am.
Next, we have Dr. Nidhi Singh, ma'am. She is also a very senior clinical embryologist with teaching experience of over 18 years. She has various awards to her credit and has been a member of various bodies like ASHRAE, IHRA, IFS. We welcome you, ma'am.
Next, we have Dr. Richa Ayani, ma'am. Madam is presently consultant head Nova Fertility Center, Jaipur, and she is also recipient of ISAR Youth Icon Award. We welcome you, ma'am. Now we hand over session to our moderators, Dr. Monica Singh, ma'am, Dr. Manisha, ma'am, and Dr. Padmaja, ma'am.
Good evening, everyone. I'm Dr. Padmaja, and after the very nice talks and the grand hysteroscopic surgery that we've done, let's get into the nitty-gritty of IVF. And I'm sharing a case scenario, and we'll walk through with what happened with her. We have Miss PS, who's 40 years. She basically got married just 10 days ago, and she has regular menstrual cycles, and she was previously married. In that previous pregnancy, she had three full-term pregnancies. One was an IUD, two cesareans, and a tubectomy was done. Her BMI is 30 years, and nothing else in her history was suggestive of anything. And so she had walked into us. They got married only 10 days ago, but she wanted to know about her fertility prospects, what she should be doing. So it was basically like a preconceptional checkup. And her partner, her husband, Mr. Y, is 36. He has one child by previous marriage. He's a smoker, and there is central obesity in both of them. As you can see, the wife is 30 BMI and the husband is having 39 BMI. So basically, they want to know what are their chances, how they should be planning things. And so, what are your thoughts on that? You can all take this one by one. Dr. Dharam, what do you think should be done? Or anyone else can take the talk. So, in this, what will be the first impression that you're making for this?
So, ma'am, can I speak?
Yes,
Dr. Gabri here.
yes. Anyone you
Yeah.
take.
So, yes. So, first of all, if she's planning for a pregnancy, this is an elderly female we are looking at. So I think we should be more concerned about her AFC. A baseline scan would let us know about it, the AMH, and definitely as the male partner is also a smoker, so semen analysis. So these are the main basic things which we should carry out to know about their fertility potential.
Yeah. And have
And
you
also, I would like to have a view of
Yes.
her uterus, how it is. Is it adenomyotic? Because she's already having 3 pregnancies in the past, and so a baseline scan will answer a lot of our questions.
Yes. And I just wanted you to have a look at the bottom of this GAD score and a PHQ score. Are you all talking about the emotional aspect, how their anxiety is? Because that also makes a lot of difference. So
Yeah.
I think not only the technical and the medical part, we need to also focus a little on that. And for people at one of the conferences when I went, then that's when I realized we focus so much on the medicine that we don't look after the couple who come to us and give them solutions. So a simple scoring system is a generalized anxiety disorder, and for a depression score, it takes hardly 10 seconds. So basically, we ask them whether they're feeling nervous, do they feel they can't control their worrying, and is it not happening? Is it on several days, more than half the days, nearly every day? More than three, you need to focus on this because this will have an impact on the fertility. Also about depression, not feeling happy over the past 2 weeks, do they have interest, do they feel down and depressed, is it not at all, is it on several days, is it more than half days or nearly every day? So more than three, you uh, definitely warrants a review, because we are not going to give them all hunky-dory news. So they should be able to take that, accept it, and move ahead. And as you said, after the clinical examination, the first thing we will be doing is an ultrasound. So do you have any particular day when your ultrasound needs to be done? And if any, can one of you read this for me? I hope it's clear. Can you see this picture? Any of the clinicians? Gauri?
Yeah, ma'am. The endometrium looks quite thick. I think like 17 millimeters you are
Yes.
writing.
Yes.
And it's a retroverted uterus. The right ovary, I cannot see any follicle as such. Maybe it's not clear. But yes, the left ovary is showing one follicle which is present, or maybe at the
Yeah.
this could not be the
So,
dominant follicle because she is already on day 25. Yeah.
yeah. So basically, in this, the right ovary had a corpus luteum. So because of those shadows, you couldn't really see it well. And the left ovary, one more thing I wanted you to notice is it is right close to the fundus,
Yeah.
and you don't really see a plane of cleavage between the uteri and the ovaries. So what we felt was it is an ovulatory cycle, but because of the very few antral follicles we saw, we felt that the right ovary was also adherent to the uterus, the left ovary was poorly accessible, and it was an ovulatory cycle. That is what we had come to the conclusion. So looking at the male factor, because that is also a very important thing, as soon as we did the semen analysis, I could see just a million. So, as you said, how smoking is one of the factors. Obesity is one of the factors that has. So, in these interventions, how long do you think we should be? How long does it take after quitting or losing weight to have an improvement? Do you recommend antioxidants, or you just suggest lifestyle and then wait for it to improve?
Ma'am, as the male is already smoking and the patient has history of previous losses also, we can assume that the DFI would be higher in this patient. So ideally, at least 2 to 3 months of antioxidants and also for weight reduction, about 5 to 10% will help, whether we are going for natural conception or IVF in this case.
Yes. So what we did was we had asked him to quit smoking. And one more thing we need to remember is on a single analysis, the result might not be. There will always be plus or minus variations. And quite a large number of time, people don't tell us if they've not slept well the last 3 weeks, if they have been under a lot of stress, if there was some amount of spillage. So it is like slowly they will come out with all these things. So we did repeat the semen analysis, and we found that we added some amount of CC, we added some amount of antioxidant, and we had the next time where we said it was very bad. We took back our words and said, I think we are okay. So remember that we need to uh, uh, tell them that we're not too happy about this, but don't commit that it is very bad, because it is always subject to a lot of variation. And so basically their idea of coming to us within 10 days of marriage is, since a tubectomy was done at her cesarean, can we have a recanalization, or is IVF the only option? So can we consider recanalization for her?
Ma'am, not with a 1 million sperm count. It is
No, the
too
count had
low.
improved.
Improved. Okay. How much?
The
Yeah,
age
but
of the
that is
female.
the thing. It had improved to 54 million later.
Oh, okay.
Mm.
Yeah,
Then we
but
So
the
go with yes.
age of the female is already 40 years. The AFC count is on lower side. And
yes,
yeah, so
And
basically,
also the obesity risk factors for surgery. So
yes.
it's better to go for IVF.
Yeah. So basically, post recanalization, it depends upon how well the tubectomy was done. One
yes.
factor that I've found is, if we are doing an interval laparoscopic tubectomy, the recanalization chances are very good, as long as people are not doing a burning of that. I mean, you just put a Youn's ring loop, gently cut it, then the recanalization chances will be better. But at a cesarean, when especially it is being done as a second cesarean, if you are very liberal with removing a big chunk of the tube, recanalization chances will be very bad. And post recanalization, how long do you assume that this lady was younger? She was just 28. So how long do you think the pregnancies take to come? Cumulative pregnancy rate, till how long can you wait after a recanalization for a pregnancy to happen? Anyone?
We wait for at least 2 to 3 months, but not more than 6 months.
No. The thing is, at least for 2 months, you tell them we don't advise conception because the
It's still
healing ectopic
healing.
chances are higher. But
Yes,
cumulative
yes.
pregnancy rates can occur even up to 2 years. So that is the problem with that. The time to conception after recanalization can be pretty long. And in a woman of 40 years with a low reserve, with very few antral found, we are not having that amount of time. So with 40 years, we remember and the recanalization carries its own risks of an ectopic pregnancy occlusion. So maybe not waiting for it is a better option. And she had an elevated TSH with high antithyroid antibodies. So should this also be taken care, or we just say TSH of 10, till then we can simply wait?
No, it should be taken care of.
Yeah,
Make it
thyroid
below
should be.
2.5.
So ideally it should be. And will you keep repeating the antithyroid antibodies to see if our supplementation is getting them down?
No.
No. So definitely it is either people have antibodies or don't have antibodies.
Yeah.
And if they have, they are there for life. And
Yes.
it also says that it is unlikely to be a transient phenomena. They might need thyroid supplementation for life. And in pregnancy, we might have to increase the dose of supplementation.
Yes.
And some studies say immune modulation will help.
Hmm.
So, and both of them had obesity. So, they had pre-diabetes, they had dyslipidemia. So, weight loss, dietary modifications are essential. Not only to improve the oocyte quality, sperm quality, also the endometrial receptivity for them. And her age is 40, AMH is zero point 0.8, FSH is 12. So can any of the embryologists tell me, like, should we be encouraging a PGTA in this case? If not any of the clinicians, even you can say.
Looking at the age, it's already 40 years, and if she's really, keen for self eggs, of course we can go with the self egg thing, because the AMH is still 0.8 and few ventral follicles are there. So we should take PGTA into consideration. There are high chances of aneuploid embryos in this case.
But Dr. Monica, I would like to differ because now it has been very well established that PGTA may reduce your time to conception, but it will not give you a guarantee to get implantation done. So we have to counsel the patient accordingly and very, very cautiously.
Gosh, yeah. But to be on safer side, I mean, medical legally, we should. Because seeing the age, we know, I mean, it's a gray area.
Yeah,
See,
it's a
what
gray
will
area. Even
happen
I
is, I
agree.
think,
It's a gray
seeing the
area,
age
but
group,
still, yes,
we,
it's a gray area, but still we agree. But still, PGTA will be helpful to the patient, and the patient should be properly counseled
Properly
on
counsel.
pros and cons
Yes.
Yes.
for the PGTA. Counseling
Seeing
is
the
very
background of
important.
both, ma'am.
Yes,
Husband also he's not
yes,
only obese, he's a chronic smoker. Even the
yes,
count was improved giving the supplements. That does not mean the quality of the DNA is good of the husband. So
yes,
in such case, as Manisha ma'am and they both are them are correct, but the counseling has to be
yes,
favorable and the option has to be given to the couple itself.
yes.
And before
What they
Option should
want
be
to
PGTA,
do.
given.
I'll rather ask for a DFI for the husband because
Yes,
it may be
yes,
a
DFI has
mix
to be
of
done.
variable counts. We are taking it as the counts has been improved, but improving count from 1 million to 54 million in such a short span is something I would like to rather do multiple analysis of this patient because this may be a patient of variable counts as well. I don't know the complete history but that is our opinion.
Yeah.
Basically,
So I
an option of advanced sperm selection while performing ICSI and followed by PGTA should be given to the patient, and proper counseling of the patient is needed in this case.
Yeah. One limitation
Dr.
for trying
Padmaja,
to
may I
anchor
add
is very,
something here?
yeah, please.
Yeah, I'm Dr. Ruma.
Yeah, yes, please.
So just I want to ask your panelists, what do they expect is a realistic chance of oocyte retrieval? How many eggs do they think one would retrieve after an IVF cycle in a 40-year-old with an AMH of 0.87? What, as per them, would be the blastocyst conversion into a stage where it can be biopsied? And what is the rate at which you would get a euploid embryo? For the patient, what matters is per started cycle, did I end up with a pregnancy or not, live birth or not? And for us clinicians or embryologists, what matters is per euploid embryo transfer, did she have a pregnancy or not? The point is, like, when we say counseling, it has to be very clear that many of these women will not have a blastocyst at the end of an IVF cycle that can be biopsied. And if they do, more than you probably need 4 or 3 biopsy because biopsiable blastocysts in order to give her at least 1 euploid blastocysts. You are probably looking at retrieval 3 to 4 times in order to get those 4 biopsiable blastocysts and 1 euploid blastocyst. You already probably have that table which says how many number of eggs you need in order to get 1 euploid conception. So, I mean, it's easy to say PGTA, but it's not very easy to implement it as a policy just because she's 40 years old. The second is, like somebody already pointed out, PGTA is not radically improving the embryo. It's just a selection tool. Remember that an aneuploid embryo has a lethality, which means that it will either not implant, which will not grow any further, or if it does, it will end up in a biochemical pregnancy, and that loss, that is around 99% if it was truly aneuploid. We also need to understand the limitations of PGTA per se, where you are biopsying 3 cells out of a total of 54 to 60 or whatever number it is, that it may not be giving you the complete picture of the inner cell mass, or also a process known as autocorrection that can happen later. So, I mean, if you ask me personally, if she made very good day 3 embryos, I'll probably transfer, giving her a realistic chance of that this will either not implant. If it does, your age-related loss rate is the same as that would be for a woman who conceived naturally, which would be around 20% to 30%. You're okay with this, go ahead. If you want a PGTA, it's all right. It's increasing your costs at the risk of having no embryos, no blastocysts for transfer. That's my submission.
Yeah.
Very well said, Dr. Ruma. That was the point I was trying to put in, because it has been now established that trophectoderm is not a true representation of inner cell mass. So you can't, on the basis of that biopsy, probably we are eliminating the chances of transferring a good embryo, which could have been implanted even. In such a scarce scenario, she is 40, AMH is 0.8, so hardly we are getting 1 or 2 blastocysts. So why not to transfer? Absolutely.
So that was the crux. The low oocyte yield will limit the potential. Okay, let's go on to the protocol and try to get the maximum number of embryos that are possible. So what protocol would you prefer? Anyone can take it?
Yeah, I personally still would use the long agonist protocol, because that is what I used for all my poor responders. Yeah. So,
anyone else?
Can use the antagonist protocol, and even can consider diostim in this patient if she agrees.
Yeah. And does anyone talk about progesterone, PPOS, pre-treatment with estrogen, progesterone? Would you start with a 3-day pill-free interval, 5-day pill-free interval? Would you want a recombinant FSH and LH, or a recombinant with HMG will do? You want to do a luteal phase stimulation followed by a follicular? So these are, do you want to, so these are all things that you need to answer one by one.
So I would like to add LH from the very beginning of the cycle. I mean, because she is poor responder and age is already 40.
So you would like to use REC FSH and REC LH, or HMG?
Preferably HMG. But if, yeah, generally that's the thing practically we are doing.
Yeah. Any pre-treatment for cycle synchrony? Because with 40 years, she will be having very less insulin.
As
yeah,
the
estradiol, well,
FSH of the patient is
Lugano.
high, as the
Yes.
FSH is high, we can ideally we should give luteal pre-treatment with estrogen to avoid this asynchrony.
Yes.
And also, according to the guidelines, ma'am, there is no difference if we are using any of the gonadotrophins, whether it be recombinant or urinary, or in fact, for that matter, protocol also.
Yeah. So we went ahead and we did an antag cycle, and you can see that when once we were looking in, we saw that we could see a slight hydrosalpinx on the right side, but since the tube is already cut and the connection is not there, we were not too worried about it. And with the stimulation, we had around 4 follicles that had grown up. And for this, we had for the trigger, do you prefer HCG, dual trigger? What do you prefer? Double trigger?
Dual trigger, I would prefer.
So we had used REC HCG 250 and a GnRH analog. And in this, at the time when we were planning, because we knew that there were adhesions, the right ovary was right behind the bladder and the left ovary was very poorly accessible. So what could you do to at that point of time, what adjustments do you make in your pickup?
Ma'am, we can go stepwise. First, we can adjust the table position, maybe a mild Trendelberg and lateral tilt. And then we can ask the assistant to give suprapubic pressure to fix the ovary. And then at last, if we are not able to assess it vaginally, we can do a transabdominal ultrasound guided pickup.
The
We
thing
can
was,
put a Alice forceps and we can just, pull the cervix down. That way we can make the ovary accessible. Otherwise, generally the fixed ovary generally doesn't, make much problem during OPU. Yeah. Inaccessible ovary can do, but the fixed ovary is generally even a better thing. The mobile ovaries create a lot of trouble.
so in this, the ovary was stuck all, it's a retroverted uterus. It was in the pouch of Douglas and the ovary was stuck there. And what we had was, we had to go through the bladder because there was no way that ovary was moving away. And there was some blood-stained urine at the end when we catheterized and saw her. There was no active bleeding, and we had two oocyte cumulus complexes that we aspirated. So with this, since now the male factor, even when we analyze the sperms here, we had active motile sperms. Do any of your, I mean, do you do IVF? Do you do ICSI?
ICSI.
The embryologist?
ICSI.
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 Given the number of eggs, we
ICSI
would
only.
definitely going with
ICSI.
XC would be the best choice.
Yeah, but some of the papers are saying that
No. Once you denude, some people say that it's do IVF.
But
Yes.
number of
Mostly
eggs
we
are
are doing
yeah,
ICSI
but
only.
we
have to eliminate the chances of total fertilization failure.
absolutely.
Yeah,
It's
that is
only
one
two
thing. Because
sides.
that is horrible for an embryologist. So I think ICSI, we should prefer ICSI. At least we are ensuring that sperm is inside the cytoplasm of an oocyte. No, ICSI is mostly done. Yeah.
While if you see the patient is already 40 years old female, so the oocyte quality which we are expecting is not of a very good quality. matlab, so we have to presume that they can be challenges. The zona pellucida can be hardened, the ulima can be fragile. So ICSI, it is not ki ICSI versus IVF. It provides more clarity to the embryologist so that decision making is easier and predicting the future is easier, I would say. And seeing the male profile also, ICSI will give a better selection of sperm in comparison to IVF. But there
So,
are studies definitely which are saying ki if there is fragile oocytes, if the cohort is less, you should go for IVF. But seeing the age group of the patient, we should prefer ICSI over IVF because one of the you can say cases where we prefer ICSI is elderly patient, 40 plus patient.
so we
Yeah,
did.
definitely in this case.
Yes, please go
uh,
ahead.
Yeah, because of as Nidhi Singh has said, because of the advanced stage, definitely we'll there is no much chance for her. So definitely taking not to take the risk of the fertilization failure. It's definitely better to go ahead with ICSI.
So we had two M2s, both ICSI done, two fertilized, two cleaved, and we had we had one 6 cell and the other was also a 6 cell with some amount of fragmentation that we had. And so since it was a low yield and we wanted to give her a chance, we thought after talking to them, we thought we will do a day 3 transfer. But then the previous night she had severe pain abdomen when she was supposed to come back. She was fine for 48 hours after that. And she went, because she had pain abdomen at night, she went to a radiologist, and the radiologist said there is a right ovary has multiple hemorrhage, uveitis, torsion, tube, pyosalpinx, adenomyosis. Do you really think that she has uveitis and torsion? Do you think she went into such a bad situation?
No, ma'am.
No.
So this is what happens when the radiologist sees.
Radiologists always they report sometimes like this. Post
Yeah.
pickup ovaries, they get really scared. Mostly they report
Ovarian
like this.
hyperstimulation, bulky ovaries.
Yeah.
Some sort of hemorrhage
Bulky
could be there,
ovaries,
but
pouch of Douglas fluid and all this.
yeah, OHSS would not be the
Yeah.
scene in this case with
Yeah.
low
And
number
as
of.
I was telling you, because
With
it
this
was
AMH,
difficult thing.
OHSS cannot be there. Yeah.
Yeah. So I always feel a radiologist should not be talking about uveitis, because uveitis is inflammation. There should be fever. There should be some abdominal distension, some signs and symptoms. So that's my pet peeve and fight with them.
Yes, it's very, very
Because,
scary.
Clinical diagnosis, this is.
yeah, it's a clinical diagnosis. So, do you think we should be transferring when she's complaining of so much?
No.
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 So that was why freeze-all was then, because of these complications, because people are so anxious, and yeah, at that point of time, anything we tell them, it is easier to freeze all than transfer, and this can implant, it can't implant. If he transfer and she does not have a pregnancy, then they're going to be the blame game is going to start, and every single decision that was taken is going to be reviewed by 30-40 people who are doctors and non-doctors and lawyers. So I think to be on the side of caution, talk to the clients, have a shared decision making, and say there is no problem right now. The With the freeze all strategy, we have almost as good as I mean, in fact, some of the studies say there are better pregnancy rates, so that's plus or minus. So that is the reason we went on for a freeze all.
Freeze.
Ma'am,
uh,
may
Anyone else?
may I say something?
Yes,
As
please.
for the history which we just now saw, ma'am, I think so there was an intervention during the pickup, and the needle had to go through bladder or uterus. I'm forgetting which surface.
Bladder.
So I don't know about other, but with my experience, ma'am, with my clinician, we usually don't do a fresh transfer in such cases when there is an intervention during surgery. We avoid doing. But if this would not have been there, she was a very good case for doing a fresh transfer, because in poor ovarian reserve, what we have observed is the endometrium is very good during the preparation time. And
Yes.
since it is good, the transfer, if you do fresh transfer in poor ovarian reserve and day 3, if you're not talking about PGT and all, since the cohort is very less, too good day 3 I have received, you can see 6 cell grade 1 and 6 cell grade 1 again with 50%, that is 6 cell grade 2 basically, but still that's a good oocyte embryo. We would prefer to transfer a fresh transfer rather than frozen. So
Yeah.
results are equally good.
Yeah.
So this is
So
something which I wanted
yeah,
to point
we
out.
had gone in through the bladder, but by the time the patient went home, she was passing clear urine and she had no dysuria and all that. So we've had, we should be very sure, give plenty of fluids. If they're a little dehydrated and you have any amount of doubt, you can catheterize and keep it, give some amount of Lasix, make sure that there is no hematuria before we discharge the patient. It is not like a blood vessel is going to go open up and they're going to have secondary hematuria. If it has to happen, it happens then. So we should be sure before we send off the patient. And if we've had a very difficult, very traumatic one, I think it's also advisable to do a for transabdominal scan, see how much echogenic free fluid is there, and then be reassured and send the patient home. And then when we started doing the endometrial preparation, I noticed a polyp in the polypoidal endometrium. So now she says, I've had so many children. Now you're finding fault with my uterus. Till now you found fault with my age. So should we do a hysteroscopy, or do we go ahead with transfer?
Hysteroscopy.
Better to do a hysteroscopy.
Better
Yeah.
to do a hysteroscopy.
So the thing is, like, she's had her children quite some many years back. And not only that, if you remember in the baseline scan itself, when we saw the endometrium on her on day 25 was almost 17 millimeters. 17, and during the
17, 17.
stimulation also it went it to 14. So that itself indicates that there is a higher chance.
Yeah.
But the thing is, like, when we say before we start the whole procedure, we will be doing all these, then some people they just drop out. So here we were hoping that it wouldn't end up in this, but we did have we ended up looking at a polypoidal endometrium. So because it can impair the implantation, it can increase the miscarriage rate. So we thought we will do a hysteroscopy and maybe allow for a cycle before we go in for a FET. So in that time, should we be doing more pickups and embryo pooling?
Ma'am, may I know we have frozen a day 3 embryo or a day 5?
Day 3 embryos.
Day 3, 2 day 3.
And why is it so, ma'am? Why didn't we allow it to go till day 5?
Now, if it had arrested, then we would have been in more trouble.
But ma'am,
Because,
it would have
because
arrested the
no, no,
uterus also,
see,
na?
we were talking about transferring a day 3 embryo to her.
Hmm.
So if we are talking about day 3 and we are saying we are not transferring today, we are going to freeze, then again I'll have to counsel them about going for a day 5. And if it does not go till day 5, then the whole exercise would have been for nothing. So
Okay.
that was the way we talked, she had asked for. So now do you want to go in for another cycle and try to get more embryos?
See,
Yeah,
ma'am,
If
if
she
it is
agrees,
Pooling, it
possible,
would be
if we
better.
can
one is
have,
if she
complicated.
agrees, pooling is always better.
Yeah, and that time I would rather take
Sometimes
it to
we
day
see
5, the
sometimes we
second
see
cycle.
better number and better quality in second stimulation if she agrees.
Yes, that is the
Yeah,
biggest
because cost could
problem.
be a factor.
So we need to talk about the timeline, the costs, and the readiness where they're willing to go in for multiple retrievals. So what do we talk to them about? The bottom line is they want to know what are her chances of success and what are the alternative options.
At the age of 40, the success rate for a live birth rate would be around 15%. So we
Yes.
have to counsel them that. In any case, it will be around 15%, max to max 20. So if they are ready to take that chance, we can go for pooling of embryos. We could have explained the pooling at the start of the cycle and then started. Or else we have options like ovarian rejuvenation or go for donor eggs.
So
I would rather put a patient on some weight reduction thing. Meanwhile, we are doing the hysteroscopy and everything, because with this BMI, there are again very less chances of conception, other than the age factor. So I always try to keep to have the patients for OPU first, and then before embryo transfer, I generally ask them to reduce some weight. At least for a couple of months, they should put some efforts on this.
So, and I think it is also like setting time limits and keeping the option of third party reproduction, adoption, and child free living. And whatever they're planning to do, optimization of their life's style, and that we are there to support their decisions is something we always have to talk, because not every person who starts in the journey ends up with a live birth. So I thank you all very much for the wonderful panel that I've had, and if my experts can say a few words, we'll be very happy.
May I just add 2 words to the whole
Yes.
case management? Excellent. I mean, who am I to say this was excellent? It was great in any which way. Just I think the debate between ICSI versus IVF in poor responders. So in your case, of course, it was done for the male factor, and I believe then there is no debate there. With the non-male factor and advanced age, there is no sort of literature or my personal experience which suggests that ICSI is better than IVF. Even in these women, see, I think we have to go by this general dictum that the minimum we intervene, the better it is for the patient. And that has been my policy. In a non male factor with a 40 or a 41 or a 42-year-old, and especially in someone whose fertility naturally has not been tried entirely because she had the tubal ligation. So that has not been tried at all. One would assume that her oocyte quality is fine, it's age related. In that sense, she's not infertile. If her tubes had been okay, she may have naturally conceived in all likelihood, because 40-year-olds do conceive naturally. The point I'm trying to make is, in this case, if this was a non-male factor, there was no mandate for an ICSI. One could have gone ahead with an IVF. That's point one. Point two is about embryo pooling. Uh, See, again, we think from the point of view of the patient. So when someone says it's a 15% chance, this is exactly what one offers to the patient who's at 40, age-related chance, 15 to 20. The decision of whether she wants to pool or not is hers, basing it on a 15 to 20% chance, even with a fresh transfer, provided all her conditions were fine. Pooling entirely for the sake of increasing her cumulative chance is not any better than repeating the cycle, maybe after completing embryo transfer process, finding out the result, and then doing it again a second time in those who did not conceive. So you would have all read the duostim versus the bistim randomized control trial paper. And what it said was the cumulative results were the same in both the groups. They were looking at oocyte numbers, whether it's higher or lesser, and just based on this, our own thinking that the second cycle is likely to produce more oocytes, their primary outcomes were oocytes, and those were similar in the second cycle, whether you did it in a strategy where you retrieved eggs, made embryos, transferred them fresh, had a result, you eliminated those patients, only the ones who did not conceive went into a second cycle, and found out that the total number of eggs per patients were the same in the bistem strategy versus in the duostem strategy. What you're doing with the pooling is that you're adding the cost of embryo freezing as well, without giving the woman that 20% chance in the fresh that she would have otherwise had to conceive. So at least my strategy has been to transfer fresh, especially in poor responders, without giving them that option of, even if it is a 1 in 5, take that chance. Let me know if you're positive or negative. If you're negative, of course, come back for a second cycle. It's up to you. I agree. This thing about retention, patient retention, they may not come back. That really shouldn't be our concern. I don't know. That's how I think. They came back, it's great. I mean, it's all right. They did not, it's still okay. Maybe they didn't find our treatments good enough, whatever. But we have to think from the patient's point of view at all times.
Thank you, Dr. Roma.
Yeah.
Basically, uh, even I'm pretty old school, like because I've been doing IVF since 2004 or so. So we see the not only as a patient who's just having, is she pregnant or she not, but over time the trauma and the emotional upheaval, the financial burdens that they have, the family pressures that they have, the social this thing. So we got to be telling them, we are there to support your decision. These are your options. I think that is, women are very logical and they're very balanced. They will take the right decision. Thank you very much.
And
And
we had Dr. Jatin Shah as our speaker, Dr. Ruma, a couple of episodes earlier, and he gave us a lot of data from his clinic. He does a substantial number of fresh transfers nowadays. So fresh, we are re-looking at fresh transfers with the same sort of optimism which we had. Like I also started in 2005, Dr. Padmaja. So that is the time we did lots of fresh transfers. So rather than them freezing the embryos, try to give an optimistic cycle with a fresh transfer. I totally agree with Dr. Ruma. Having said that, there are different management strategies for different clinicians according to the dialogue they have with their patient. Thank you so much.
But ma'am, here I
Only
would like
one.
to ask one question. Like Dr. Gauri was saying, she would like to go for blastocyst transfer. So, what is
Yes,
the
yes.
opinion of experts? What
Yeah, like why in this case or any case of a poor reserve, ovarian reserve, why are we even thinking of day 3? Why not give a day 5? Because it is just going to decrease your time to pregnancy. Aren't we very sure of our laboratories? Why are we doing this day 3?
and it may be a case
Or
of
are we
putting
not are
medicine
we
like
not sure about our counseling skills? What is it that is inhibiting us from taking it to day 5?
Yeah, so understand that studies on at least the overstimulation, where you have hyperstimulation, day 3, you have the PCOS women and you have the non-PCOS women, right? In the PCOS women, there have been trials on fresh versus frozen for day 3 and fresh versus frozen for day 5. And it has been said that it is always the frozen transfer, whether it was day 3 or day 5, that would give you a higher rate, right? So in a strategy where all PCOS women underwent, either a day 3 fresh or freeze all and a day 3 frozen, you'd find that a day 3 frozen would give a higher pregnancy. And there is something known as endometrial embryo synchrony that is at play here, because PCOS women have higher estradiol levels, and progesterone levels are likely to be higher. The endometrial synchrony with the embryo is broken. And this is broken furthermore for a day 5 fresh versus day 5 frozen. So that the results are even lower with the fresh day 5 in PCOS women versus a frozen day 5 in PCOS women, right? When you took this same theory to the non-PCOS women, the ones who are considered average responders, not PCOS responders, you found that day 3 fresh versus frozen results were similar. Okay, in average responders, the endometrial embryo synchrony was all right till day 3, but with the day 5, there was a marginal reduction with fresh transfer when you were doing an embryo transfer on day 5. So here, fresh versus frozen. Do you get what I'm saying?
So
This is
basically, in a
average
in
responders.
a normoresponder,
In a normoresponder,
in a
right?
normoresponder,
Now,
you are
poor
saying that
responders don't make it to trials. Also understand this. There haven't been trials, these trials for fresh versus frozen poor, like really
no,
well-funded,
if I'm getting you
no
right,
bias trials.
you
Yeah.
mean to say that in a PCOS, frozen is better than fresh. We all do
Whether it was day
frozen,
3 or
right?
whether it was day
Yeah,
5.
yeah. So there is no question about that. We all do a frozen out there to avoid OHSs.
That
How
is
about the normoresponder? You are saying a day
5
day 5
would give you a lower fresh transfer result than a
fresh
day
transfer.
5 frozen. Yeah.
Fresh transfer would be lower.
Lower than a day 5 frozen. So
Yeah,
in
that is
this,
okay because anyways, fresh transfer has a lower rate, usually according to some
but
studies.
not for day 3.
Okay, okay.
Not for day 3. There is an
Mhm.
embryo endometrial crosstalk. I'll just take this call. Kajal, I'm in a meeting. I'll just call back. Yeah. Okay. So now this data we don't have for poor responders. What is happening to them with day 3 versus with day 5? But one assumes that the embryo endometrial asynchrony or dyssynchrony would be higher for day 5, even in these patients. It's not like we suspect our labs.
So,
We don't
so,
trust
so,
our labs.
so just because you are doing a fresh transfer,
In
to avoid that embryo, this asynchrony,
Yeah,
you are
because if
trying
she
to put
makes
it.
a day 5, I would prefer, and I'm not supported by evidence here because evidence does not exist, in a poor responder, if she makes a day 5, I would prefer to freeze it and
Freeze
transfer
it.
in the next cycle. Yeah. In a
So why
frozen.
not do this for everybody? That's what I'm see because none of these embryos, maybe they won't make it to day 5, even even in your lab or maybe inside a body. Why are you putting it on day 3 of fresh transfer and
Results are
giving
the
her
same,
the
Dr.
false
Gauri.
hope of a
No,
pregnancy?
results are the same. You could do a day 3 and use that as a denominator, right? So the number of women who made day 3 embryos, if you were to split them into two groups, one who received day 3 fresh transfer and the other who go on to culture and then receive a transfer of day 5, right? Those are, your results are the same.
No, how can it be? The time to pregnancy is always less in
No,
a day 5 transfer.
results are the
Definitely.
same. In the same group, in the same
See,
set,
if
in
you
your same
have,
study.
if you have, at
Okay,
least
we
you agree this, if
will
you
not
have,
take people's time. I think we'll
yeah, okay.
discuss the
No,
set.
no,
Okay,
this
let's
is
see if
not.
you have day
Day
3
3 versus
embryos,
day
not
5,
all
if
of
your
them will form a
denominator
day
is
5,
number
right?
of women who made day 3, will be the same. All right. We are not taking day divided by day 5. The denominator has to be the number of women who made day 3 embryos. And now one receives fresh day 3 and the other receives culture followed by a day 5 transfer. Your results are going to be the same because some of them fall out, they'll not make day 5. The others who receive an embryo transfer on day 5 will have a higher per embryo transfer result, but not per started cycle result. They'll have
Dr. Roma, this is a very interesting discussion. And I think what Gauri is stressing upon is time to pregnancy,
Yeah.
the TTP. So tell me, Dr. Roma, as an expert, how important is time to pregnancy in a poor responder while selecting whether that patient should be cultured or not?
Right. To that, I have just one question. In the day 5 culture strategy, right, you allow it to culture, and there'll be two sets of women. There is a set of women who make it, and there is a set of women who don't make it. Right? For the individuals who make it, you will do a transfer. For the individuals who don't make it, you will wait it out till her period day, which is the second day, right? You are still losing those 14 days and we are going to restart a stimulation on day 2. Right? How are you increasing her time to pregnancy or shortening her time to pregnancy? It still remains the same. You have to read the Cochrane reviews
No.
on
It
day
is
3
time
versus
to
day 5.
pregnancy per transfer. We should take into consideration. We
Per
should take into
transfer is
consideration
always
the
the wrong
hope, the
denominator to have.
monetary loss,
Understand
and
this.
the hope what she is
Come
like
on.
per transfer. Her
It has to
losing
be per
support.
patient. It's never per transfer. It has to be per patient, per enrolled patient. So if I am an IVF patient and I started out, you could give me any of the two strategies.
Okay. Let's take into consideration she has 10 day 3 embryos. Okay. Out of that, only 3 are going to make it to day 5, which will lead to a baby. Okay.
That's a strategy
You are
for higher
suppose.
numbers. That's a strategy for
Okay.
embryo selection.
Yes.
For
So
a poor
suppose.
responder with 2 day 3, you are risking also a very large population who will not make it.
Yeah.
Gauri, can I answer?
The
Gauri,
blastulation rate is about 40% in the best labs.
Yeah.
It's not more.
Roman, can I tell an embryologist point of view here?
Yes.
See, when the embryos are less, if we can take this case, Gauri ma'am, I do agree to you, but I'll tell you my perspective. Like if I have multiple cases of poor ovarian reserve, so the first thing which I do is the communication with my team, that is with my gynec. I need to know, ma'am, what is the counseling and what was the outcome of the patient counseling when they were told that your number of oocytes are going to be less, the number of embryos formed may be less, and then the outcome, that is whether the blastulation rate is as expected 60%. So if there are two embryos, only one may be forming a blastocyst and all. So a very simple thing which I come to know is that there are certain patients which when I communicate, they say कि निधि इनको तो embryo डालना ही है, because the patient is having a mindset कि I need a transfer, I want a transfer, so there is no choice कि I cannot go without a transfer. So in such cases, we prefer day 3 transfer. There are patients who are well counseled, especially in patients who are, I would not say educated or uneducated, but who have better clarity about it. As ma'am, you were asking, will you prefer as an embryologist go to day 5? I would definitely prefer with the two embryos also. Why? As you said, at day 5, the clarity will be there whether these day 3 embryos actually formed a blastocyst or not, especially in this case where the male factor comes to play after day 3. So there are a lot of cases where the embryos get arrested after day 3. So we have multiple cases which we have faced that, but the patient is well counseled that on day 5 you might not have any transfer and you might not have any blastocyst, and they are content. But if the patient is not having that mindset, he's a little hyper and the
Yeah.
family
फिर
situation
तो
is
हमने
there.
हमारे
So we,
स्टडी डेज में एनएस डालते हुए
yes,
भी देखा है ना?
yes, ma'am. So that is what I'm saying. We talk to the gynec actually. we ask him, ma'am, what is the expectation of the patient and what is your expectation? Then only we go for further day 3 freezing or day 5 culture. So this is the turning point, though. This communication is with every person on day 3. So both of you are right, actually. So,
No,
but
no,
I'm telling
I
my
agree with
perspective,
you,
ma'am.
Nidhi. That communication
Yeah,
has to be there. There is no.
yeah. So that is my point as an
Just the
embryologist here, ma'am.
understanding on whether we prefer that day 3 transfer is going to increase the time to pregnancy is incorrect, and I'm trying to counter that.
Yeah. So,
Day
Dr.
3
Rama,
transfer
you are
is
very
not increasing the time to pregnancy.
Yeah, so points well taken. A very, very interesting discussion. So I allowed the case one to go on to this extent because it's very relevant. This is why we are together, and this is why Dr. Ruma has been invited. So, Dr. Ruma, just a last layman question before we close this case. Uh, is blastulation rate better in vivo as compared to in an incubator? Is there any study to that effect?
I mean,
Would
there
there
have
be, would
been
there
all kinds. If you look at animal studies, but animal studies, the blastulation rate is anyway very high. You know, mouse embryo blastulation is to the tune of 80%, as opposed to 40% if your denominator was 2 PN. But there are studies that look at how quickly the blastulation is happening inside versus outside, in vivo versus in vitro, and in humans. And it has been found that blastocysts form slightly earlier in vivo than they do in vitro. See, what you have to understand is despite the best conditions, no matter where, they're all controlled conditions. There's not one variable, there are some 10 variables that you're trying to control: CO2, O2, moisture, pH, humidity, so much. Of course, the operator, how you're handling it, exposure times, and what is happening to it in the last 5. Despite everything being perfect, this kind of control, this kind of the tight control that you need to exercise outside and make sure every variable falls within limits, is not something that you need to do inside, right? That is what is the word for it, where it autocorrects. Yeah, it autocorrects and it happens everything inside. So I mean, ours is of course a lab that does 80% blastocyst culture. You know that in Gangaram, that is what we have done. Dr. Nidhi is from Gangaram Hospital. She is trained there, and she would probably tell you this. So we are really not, and we are one of the we have been doing it for the past 10 years or so. My point about a day 3 transfer, this is like coming back from a day 5 to a day 3, especially in poor responders. In a case here, is it does not stem from a lack of exposure to day 5. Day 5 is the norm in the lab. That is what it is. Here, what we are trying to say is there is a little element of endometrial embryo asynchrony by day 5 that we are disregarding, perhaps, in a woman who has, in any case, a 15 to 20% chance of conceiving per cycle. And that element can be reduced by doing a day 3 transfer. That's one. Second, that in a day 3 fresh versus a day 3 frozen, we have evidence from self studies, from literature, that results are going to be the same in a poor responder, day 3 versus. In fact, you're adding an element of another intervention, which is freezing, thawing, and I'm sure everyone would agree there has been, even if it's a 1% loss rate, there is some such. Or where the embryos don't expand, where you can't find the embryos. Even in the best laboratories, that happens. So you don't want to, you're already working on the margins. You don't want that going down by 1% or 2%. Knowing that a day 3 is equally good as a day 5 if she were to make that day 5, right? So blastulation rate, I'll be frank with you, if your denominator was 2 PN, it is close to around 40%. This is utilizable blastulation rate. And this can vary when it's, the age is 25 versus the age is 40. So you have to understand that. Of course, they're chatting and they're talking because patients are very clever. They always ask me, why are you not doing a day 5 in our case? And all this discussion has to happen at that point. It's all right. I'm happy to do it. Just understand that half of you will not have an embryo for transfer. It's got nothing to do with the lab. This is how intrinsic day 3 physiology works, day 3 embryos. Not every day 3 embryo will go on to the blastocyst stage. If you're fine, I'm happy to do a day 5. Also understand that there is a small element of endometrial embryo asynchrony by day 5, which might reduce your results by 2 or 3 percentage points.
Thank you so much for the clear message, Dr. Ruma. Really, really appreciate.
Yeah.
And my
Seriously.
thanks, Manisha, for bringing up that question.
Actually, that is something very debatable, and this is a general notion. Day 5 is better, but there are enough literature, and I'm so convinced, and I'm so grateful the way Dr. Ruma has put it in words that it is not always a good idea to go for day 5. Absolutely, you are putting them to unnecessary epigenetic stress when you are having a very little amount of.
So also I would agree with Dr. Gauri on 10 day 3 embryos. Your day 5
Yes,
culture
that
becomes
scenario, definitely.
your
Mandate.
day 5 culture becomes a selection tool. That is
Yes.
perfect, right? That's all right. You know that you'll
And
end
I
up
believe
with
it
2,
was
3.
started as a selection tool because in many of countries you can't do the reduction and you can't opt for embryo reduction and
And
all such
also it
things. So
becomes a
to
great
prevent
tool
those,
for single embryo transfer when
yes,
you're
single
doing
embryo
blastocyst
transfer, when you want to
That's all
select
right.
the best one, you should go for day 5. It shows so many things about the lab, about your culture system. It is a great choice. But in such scenario, in case of poor responders, going for a day 3 is again a very good idea and a safe option. And literature is supporting that now. Now we have enough literature. So with that, moving on the next, Dr. Monica, ma'am, shall I take the lab aspects?
Yes, please take one case, Manisha,
Yes,
because
absolutely. We are getting already very late. So
choose,
after such an interesting discussion, you wanted to say something, ma'am?
no, choose the case which you think will be most suitable for this setting. Yeah.
Simply, since a lab is a kind of black box for IVF cases, so how to approach for troubleshooting in lab scenario? My idea was simply that after such an interesting case, the cases we are going to discuss today, the case we are going to discuss today is not something very rare or difficult or dramatic. This is a very routine IVF scenario that every laboratory encounters an IVF failure, and keep it in mind that an IVF failure does not always indicate an error, but an unexplained failure always demands a careful analysis. Through such cases, we will focus on a disciplined and comprehensive troubleshooting framework, how to approach failures methodically, recognize deviations, and audit objectively, and to identify the root cause, which without bias or without blame. That is the whole idea. So, keeping this framework in mind, let us now examine our first case. Let me go full screen. Can you all see my screen? Is it visible?
Yes, Manisha.
Yes.
Make it full screen, please.
Yeah. I'm doing that. Yes. So this is the case.
Ma'am, it's
So
not visible.
yeah.
Screen sharing has stopped, ma'am.
Yes. So this is a case, a very simple case. A female of 32 years, tubal factor infertility, AMH was 3.1, AFC was 8 to 10. Both the side, male factor was absolutely normal. And if we, so case was very simple with high expectations from the lab. Oocyte retrieve were 14, M2s were 12, and still we opted for a ICSI as per patient's wish. So we were expecting a very good outcome, but when we saw the results, we were a bit devastated because fertilization was not that good.
Ma'am, screen is not visible.
Your
I think
screen has
Yes,
gone,
you
your
have to
Manisha.
share
screen
the
is not
screen. It
visible.
has stopped sharing, ma'am.
Please
Oh,
share
The
the screen. Share
yeah.
your slides again, Manisha.
okay. Okay, just a minute. Let me see what has happened. Oh. Just a
Ma'am, you have
minute.
to restart the screen sharing, ma'am. It has
Yeah,
stopped.
I'm doing that.
Yes,
So,
ma'am. Done.
so
Visible,
you
ma'am.
must have seen the history. So female 32 years, tubal factor infertility, AMH was good, male factor was normal, oocyte retrieval was 40, M2 were 12. So classical, a good prognosis case. ICSI was done as per patient choice. But when we saw the outcome was very disheartening. fertilization, which was according to our lab KPIs, it was like only 33%, which was very, very poor. Cleavage was not, which was expected to be symmetric. It was fragmented, uneven. Day 3, we could get a 3/4 cell stage, and there was no blastocyst which can be transferred in such scenario. So according to you all, clinicians and embryologists, anybody can take up, is this within biological variability, or is there any lab-related issue? How would you approach this case?
Can I begin with this?
Sure,
Am I
sure.
audible? Yeah.
Sure.
So we often, like everybody would agree, we often have such cases, at least, I would say, probably 2 cases in a month at least. For such cases, what I found very helpful is we see the entire spectrum. So we take the clinical file in our hand, probably sit with the gynecologist also, and begin from the beginning with the clinical picture, and then gradually get into the lab aspect also. So me focusing, let's begin.
I have what else you want to know? I have given the complete picture, and this case has shown a good laboratory outcome, a good like a blastocyst development in previous cycle. In that cycle, it was a implantation failure case. So.
Right. So yeah, it definitely is not a straightaway cases. I would definitely agree to that. In such cases, what I would do is there are around 4 to 5 pillars of the lab, like I would like to call. So we would go and have an audit on those 5 pillars, 5 to 6 pillars, which are the basics. Like you start with your gassing system, your AVAC, HVAC also. Check your media and everything.
So you would like to check the incubator, the VOC count.
So keeping in mind that we are doing all this once the case has been done, and we are doing, let's say we're sitting in February and we're checking a case from the beginning of February, maybe January case. So I would definitely like to check all those pure basic pillars of the lab, which is of course the air quality, the consumables we are using, the media we are using, and definitely the operator will have a chit chat with that also. So I think if we go in detail with the entire thing, we might be able to find something for this. However, I would also like to say that if there's anything missing in those critical parts of the lab, it would be not only hampering a particular case, it will be having a snowball effect on every case.
Right.
Yes.
Absolutely.
So I think I have created a more confusion than clearing something up.
No. So, Dr. Mahipal, I would rather suggest you to start with pattern recognition. First, find out if this is a standalone case, or this is happening in more of the cases which are being done in the same time period. So in such a scenario, that was the approach used by us. We always do a pattern recognition, and in this with this case, when we investigate, we could find 2 more cases which are being which were going on in the lab with the similar outcome. And so now where to go? Anybody else would like to add anything? And here I would like to ask clinicians. If these 2 cases are not there, if in case you are doing just a single this case, what would be your would you like to investigate it, or would you like to treat it we need to audit?
Sometimes overstimulation also causes poor cytoplasmic maturity of the oocytes. As this case showed that the cleavage was very asymmetric, not symmetrical. So it points more towards intrinsic oocyte quality and contributory lab factors as well. So we should review the stimulation protocol for how long the gonadotrophin dosage was given, the triggering time, what trigger was used, everything.
Absolutely.
So can I add something to this?
Sure.
I didn't see the previous slide clearly. If there was something, the semen parameters were informed that
absolutely normal, absolutely
perfectly
normal.
okay, right?
Yes.
So even though we don't have any concrete proof for it, but I would have a slight doubt on the semen also, the sperms used for the ICSI also, because we have a low fertilization, and then we've got day 3 low-grade embryos also. So male genome starts beginning to act around day 3, end of day 3. So would that be probably? Can I just throw it into that? Can that be a factor which might be affecting?
We'll see to it. Anybody else would like
But
to
in this
investigate
case,
anything?
Manisha, you have already told that they had done one cycle and they had got blastocyst in that cycle.
Yeah.
So we cannot suspect in that case an patient factor. There would be something else that had gone deviated.
So what would you like, Dr. Fasina? Actually, I can't see any of your faces, so I believe. So what is
What gonadotropins were used? What was the batch? Also, we should look. Sometimes the injections which are used, batch variability among the gonadotropins also sometimes
But the
decrease the quality of oocyte.
follicle development was absolutely normal. Pickup was done on day 11. Size of follicles and everything was picture perfect. It was absolutely without any doubt a tubal factor case. So everything was going well.
Ma'am, actually, as you said,
Ma'am, even this week I had a donor. I mean, obviously for donors, people say ki, they go and give in multiple centers in spite of the new law. So the day the egg quality was good. I mean, it is very rare the embryologist write in the sheet that the quality was good. Sperms were good because they have a live kit from the previous IVF. And now I have got blastocyst from like 20 some eggs. Although we have not reported so, sorry to say in this panel, but I got 7 blasts and all of them BC, 3AA, 3BC. So actually, you are stuck with these sort of cases. In spite of the embryologist telling me the egg quality was very good, sperm was very good, count is good. So actually, I myself and the same gonadotropins I have been using for the other patient also the same batch. They have got A grade blast. So
that is the importance of pattern recognition. You are using same gonadotropins for the other patients and they are working well. So you can't blame gonadotropins here. Somebody was mentioning gonadotropins.
Yes. I was the one who was referring, but I mean I don't know the cause actually.
So
even the lab they're taking.
So that's what I'm saying. Go systematically. Like do the pattern recognition. Then if a pattern, you find a pattern, do an audit. So now here comes the role of audit scope. As Dr. Mahipal was saying, audit scope should be broad enough to incorporate all the things which you can think of. So like incubator performance, incubator logs, gas calibration, air quality, VOC, we were mentioning, ICSI handling, exposure time. So recording all these things are very, very important. Consumable plasticware, their batches, and culture media and oil. We somehow missed saying that because this thing is consistently happening to 2 or 3 cases. So how we can't think of culture media and oil? They are again an important contributor, isn't it? Somebody want to elaborate anything here?
I think for the causes of low fertilization, it can be multifactorial. We cannot blame any one parameter, and based upon that, we cannot come to the conclusion what might go wrong.
Harika, when we need to do an audit, in case of case failure, when we need to do audit, we as an embryologist, we have to find out what went wrong. So how will you do the audit? So
yeah, I think in during this audits, we can have the Ishikawa fishbone chart that really helps. We can sit with the team of our embryologists, and we can have the brainstorming sessions of what might have gone wrong. It can also happen that it can be the mistake of the operator, or like I'm not blaming the skill of the operator.
So definitely. So plan an audit, keep the scope of audit broad. Then identify the stable systems. The next thing, incubator performance, it was stable. There was no log of disruption, alarm logs, no events, gas calibration within the limit, VOC exposure, no change. Embryologist, check the embryologist, her competence while doing these cases. Although as of now, till now, that can be a debatable issue. Consumables, same batch. So in this case, what we could find out, the only variable changed in our lab was media lot. You know,
Yeah.
we have used a new media. What happened in our lab? So we go very systematically, and here I would like to discuss how to do
Sorry,
troubleshooting
Dr.
inside
Manisha,
the
can I
lab.
jump in?
Yeah, sure.
I had a small question. So did you change the media brand or was it just the lot which you changed?
New lot. It was just a new lot. It was the same brand. It was just a new lot. So when all systems are stable, we look for variable changed. And this introduction of new media lot, because embryologist was same, he was doing the same exes since long. So we pinpointed this media thing. So now I would like to know, Dr. Fasina and all senior embryologists are there. How do you validate media lot? And routinely, and is it needed to be done?
Even ideally, it is said that we have to validate every media lot which we are doing,
Yes.
but
But how to
practically,
do
But
it?
I am not doing
practically,
it.
it is not possible.
Practically, I am not
Practically, it
doing
is
it.
not
Not
Yeah,
possible.
possible.
Nita ma'am, you're right.
Yes.
We are not doing it
Yes,
practically, ma'am.
practically, we are not, none of us is doing validating the
Yeah,
batch, each
yeah,
batch lot.
yes.
We are not doing it because hardly see 10 ml bottle you are taking, and if
Mhm.
1 or 2 ml you are utilizing for checking the lot of pH check or everything, so that is practically not possible.
So
But
validation, how would you like to do if given a chance? If once we have faced such scenario, we started doing it. So what is the right way of doing validation? How can we do it? Because media is a very important component
yes,
of our culture systems. Anybody? Gautam?
Yes,
I
ma'am.
think best thing is to go for sperm survival test, Manisha. That is the easiest method to check the
I think it
yeah,
is comprehensive and it is robust enough to talk about the embryo culture.
no,
No.
it is not.
I agree. We don't routinely
Yes,
check the osmolarity
routinely
of
we
our
check.
meat.
If we talk theoretically, each media lot has to be checked before it is used. pH of each media has to be checked before we want to use.
So
But
pH is again debatable, and we all
yes,
agree pH is not sufficient. If we really want to validate our media, we have to check the osmolarity, and which is very
yes,
difficult to get is checked until unless you have a blood gas analyzer.
yes,
And so
yes,
I'm
and that
working
is
in a
difficult. Yeah,
that
that
is
is
difficult.
difficult. That is
Fortunately,
difficult.
I'm working in a multi-specialty setup. So we are having a blood gas analyzer and relying on the symptoms like the evidences like biological validation is again a robust proof. So embryo response was clearly reflecting osmotic stress, pH instability, and toxic exposure. The way embryos were growing, it was a clear-cut indicator. And as I've mentioned, that embryos are the most sensitive biosensor. So we looked upon this case with the media we are using, and since new culture media was introduced, so how to validate that media? It is the simplest trick is do a parallel lot validation.
Yes, parallel lot.
Validation. Instead of
Yes,
sperm survival, I will
yes,
recommend doing a parallel lot. Don't use any new bottle in immediately in full clinical use. We used to do that, but we land into the trouble of spoiling 3 cases. KPI deviation we don't anticipate, but this is the thing which had happened in our case. So it was not a blame of embryologist. It was just a process was deviated. So how to validate what is parallel lot validation? Just for the information, is start doing split culture whenever we are using a new media inside the lab.
yes,
Don't go with the certifications only. Always do a split culture. Half of the embryo you should culture in a new media, and half of the embryo of the same patient culture it in a new media. Do it for at least 2 patients and compare their biological performance, and don't blindly go for the certification. And when after doing that, when we actually in this case, since we were suspecting media, so we went for root cause confirmation, because since we have blood gas analyzer, we checked the osmolarity of the retained media, and osmolarity was 20 milliosmol higher than the acceptable range. So in case of blastocyst culture, the osmolarity we are expecting somewhere 295 or something. So it was higher than that, above 300. And we contacted manufacturer, and after talking to them, we have realized that that manufacturer certification will ensure you about their production process. They'll not ensure you how that media is going to behave inside your lab. And if you are using it for many patients, we should be cautious about it. So, and when we talk about accountability and clarifications, we always think in that manner that no, it is not an individual embryologist failure that he has not checked. Generally, we don't check. It was not a clinical protocol failure. It is system level process labs, because we generally don't validate media, which is easily which can be done. And accountability, if we talk about accountability, it should be treated as a system correction, not a blame to any particular person. And we should always consider IVF failure is not always an error. It may happen. Pattern recognition should be preceded with a detailed audit. Isolation help in finding out the variables, and embryo response are the most reliable indicator. Media validation must proceed in routine use as well. So with this, I'll end this case here because we are already running very late. If anybody want to add anything to this, you are welcome.
Instead of adding, I've got a question again.
Sure.
So you found that there was something wrong with the media.
Yeah.
Were we able to pinpoint what led to that? What was the real cause? Did we use the bottle for too long, or was it faulty from the
Yes,
supplier?
we try to find out, but we can't get the same kind of
Question is
response
just to
from
learn. I just wanted to know
other
in case we
labs. So
find.
it may be what we have assumed, it may be a handling error or a transportation error. Sometimes cold chain was not maintained or something
Yeah.
like
Ma'am,
that.
we had a
I have a question
Yes.
for embryologists here
Yeah.
that how, like one thawing media vial, you use it for how many cases? Is it like recently I had a problem with the thawing media. Like the embryologist said, there were A grade blast. There was some issue with the thawing media.
Okay.
So like uh
How do
the
you know
very
it?
high
Was the
AQI in
issue with the
NCR.
media?
So
How do we
how
know?
many days you keep that vial? I mean, I don't know exactly. Like thawing media you use for how many cases?
It depends on the kit, which kit you are using. It depends on the kit. Kitazoto or it is Sage, which kit you are using.
And while
Kitazoto.
thawing media or
Yes.
any media, you should go with the manufacturer's
Manufacturer.
protocol.
Yes.
Don't deviate from those things.
One
These
more
things
thing,
happen.
No, the
date of
same media
opening.
was A grade blast positive with one day and the other day negative. Is it? I mean, I'm not saying all A grade blasts give pregnancy, but what I'm trying to say is that there are obviously, like, as a clinician, you see that transfer was good, the lining was good, the embryos were good, and then like you said that you go back and check. So I also try to take out things, but then somehow it came out to be maybe because of the thawing media. Now how to do that? I mean,
So
maybe
if
nobody is to be blamed.
Yeah,
post thaw, you culture your blastocysts. If they are expanding well, that means your blastocysts are viable. There's no problem.
And your media is good. If the post-thaw survival is good, expansion of the blastocyst is good, then the media is not debatable. If the proper expansion is there, then we cannot
Okay.
blame
Be sure
the
about
media.
your media.
If the blasts are expanding, that means the media is not to
They
be
are growing
blamed.
well.
Yes.
Yes,
Okay.
you are safe. So never transfer blasts just after thawing. Culture them at
Yeah,
least.
we keep 3 hours for our post thawing,
Yes.
and
Yes,
then
that is enough time to see the
Expansion.
expansion.
So thank you, Manisha and Dr. Jayashree. Very nice. I mean, these discussions bring out these small queries which we
Yeah.
probably can't ask in big conferences. But in these webinars, please feel free to ask all queries because we've got these gems of embryologists with us. And I think with Manisha and our team, we are learning so much of good embryology and take home messages. I'm so thankful to you, Manisha. Because of Garima, we could get great endoscopists today. Means it is a virtual feast. We are having a mini conference out here. So thank you
Yeah.
so
Thank
much.
you so much, ma'am, for this webinar. It's really nice.
Thank you. And
Um,
for your information, this webinar will be available on YouTube. If you want to watch any lecture again, it's going to be there in our YouTube channel. I'll put the link in the group very soon. And because of we've already exceeded 3.5 hours, so I think we'll end it here. We have two
Ma'am,
cases remaining,
just
but
one
yeah.
little thing. Can I
Yes,
just
Gauri.
chip in?
Yes,
Like
please,
this
Gauri.
case
Yes,
is
go ahead.
going on.
Yeah.
So we had a similar case like what Manisha just mentioned last month itself, wherein our three cases went, just bonkers like this, wherein embryos, whatever we were expecting, didn't form. One was a case of, oocyte freezing. She wanted to, do it do the ICSI with her partner. That case went waste, and cases which we really didn't expect to go. And similarly to what Manisha had, we checked everything, nothing was found wrong. And ultimately we got to know, like, since our fellow people working in the same area, that this media could be a problem, because they were also having problems like with the same media batch. So the batch was changed, and unfortunately we didn't have any blood gas analyzer to cross check. So today maybe I have the answer, but then we already got to know it was a media problem, because surrounding laboratories had the same, because we all are like friends. So we come to discuss about it, and we got to know that they also with the same media batch had the same problem. Yeah.
So never, that's what I'm saying. Never rely on their certification. Batch problem is something very, very evident. You can make it out. But
Yeah.
when there is a problem in supply chain, you won't be able to know until unless you have this kind of
So
strategy.
just like our HMGs, now we have a problem with the media also now. Yeah.
It can happen.
Yeah.
If your
Too
supply
bad.
chain is not sure, I couldn't find any issue with the same batch of media in any other lab.
Yeah. Yeah.
So it must be some issue with our supply chain or our
Maybe.
storage process.
Okay.
So you have to be really, really vigilant about everything, where you are storing, how you are getting, and how often you are opening the bottle. If you are buying in big volumes, I'll always suggest aliquot them properly, and don't freeze thaw, don't bring them to temperature changes very often.
Yeah.
Otherwise, don't buy big bottles. Opt for the
Yeah.
small.
Yeah. So
Yeah.
ours was a small bottle, Manisha, just 10 ml for all the three cases, all three cases gone.
I know there must be, as you found it out,
So,
there must be.
Manisha, this gas analyzer is not a very big investment. Do you think it can help? We should start keeping it?
It is of immense help, ma'am. In such scenarios, and or if you don't want to invest in blood gas analyzers before introducing a new batch, always validate what is harm in doing a split culture when your bottle is about to end. Please, if it is working well, please take always ensure open new bottle beforehand.
Yeah. That was a very good point.
And
Very
split
good.
culture. It is the easiest thing to do.
Right, right. Before your previous bottle ends,
Finish.
you open a new bottle
New
and
bottle,
do a split culture. That's a
Split
very
culture.
good,
That is
very
the
good thing.
easiest thing.
Very good, very good.
Don't wait for the audits. I mean, after the mishaps, always do it time to time. That is the best idea.
But
So please,
sometimes mishaps teaches us so many things. Is doing.
See, we Indians are very good at jugaad for everything. We
Yes.
don't need fancy audits. Everything goes on in our minds.
And here I would like to recommend one more thing. Don't take it. There may be a biological variation. If you
Yeah.
are finding any result a bit unusual, always investigate it properly. Troubleshooting is means investigate that thing thoroughly. Go do it in a systematic way. These things are available on the net. We should implement these things, audits. If they are being done in a proper way, they'll give you answers.
SOPs and audits, they are the key factors for the success in analytical.
Right.
So that brings us to the end of this episode of Perfection series, episode 9.0, brilliantly put together by my co conveners and my coordinators, and of course, all of you. Without all of you's viewership, support, and inputs, we would not reach the level of excellence we've reached already. And the panel discussion was definitely icing on the cake. So, thank you so much. We are going to have two webinars very closely placed, and please do not miss them. 13th of January is our 10.0, and we finish this series with an 11.0 on 18th of Jan. Then we'll start a fresh season after a little break after Isar Ahmedabad. So thank you all. Good night
For
and love
being
you
here.
all.
Have a lovely evening. Thank you so much.
Thank you so much.
Thank you so
so
much. Thank you all.
Thank you so much, everyone.
Bye. Good night. Thanks, Team BSV. Thanks, Anmol. Thanks, Deepika. Thank you all. Bye-bye.
Thank you
Bye.
all. Thanks.
Bye.
Thanks.
Thank you, everyone. Thank you.
Bye, ma'am.
Bye. Bye.
Bye.